FutureMed 2020, the conference that would cover everything about the COVID-19 pandemic, from crisis management to how we use innovation and entrepreneurship at a time of a crisis to foster better caregiving, and also about how we accelerate science for the benefit of humanity. Such a great pleasure to introduce the initiator and the chair of this conference, Professor Ran Balitzer, who is the Chief Innovation Officer of Clalit. Clalit is the largest health provider organization in Israel and one of the largest of its kind in the world, and known around the world for its innovation, the use of data, and the way that you change caregiving through technology.
Yes, thank you so much, Nimrod, and thank you for taking this role as a host of this exciting day. Indeed, Clalit is the largest healthcare organization in Israel, and it has been involved in using data and technology in an innovative way in order to revolutionize and change the way we practice care for the millions of members, over 52% of the Israeli population. And I think that the challenge that COVID-19 has brought upon us made us truly soul search ourselves and try to see how can we really leverage all of this experience in order to better cope with this ensuing challenge.
So today we are going to talk about all the challenges that were introduced to humanity at the time of this pandemic. How do we do crisis management? We'll have an exciting session to talk about crisis management in comparative analysis from around the world.
Definitely so. And so there will be several viewpoints on crisis management, on accelerating science, on technology. This is going to be really a very, I think, dynamic day that is going to be unfolding in front of us. And we are very fortunate to be able to have such a group of luminaries spend time with us and share with us some of their thoughts, some of their experience, some of their aspirations for the future, and some of the insights and their lessons learned that will allow us all to do better as we try to cope with the challenges, each of us in our own country, in our own organization, and actually to some extent in our own family. We are all really somehow moving in the dark and trying to find the right path forward.
I think in this conference, we'll try to see whether we can move less in the dark and be enlightened by technology and data. I think one of the highlights of this conference is whether data could be used to better do crisis management, better predict for the future, and better plan and even innovate at this time.
Yes, we will talk about data, we will talk about artificial intelligence, we will talk about drug development and vaccine development. We'll be talking about decision-making in epidemiology and decision-making in a business and decision-making in policy on a nation level, on an organization level, and on a local level. And all of these will be discussed by, I think, the most qualified people in the world to share with us some of their ideas and experience. And with no further ado, to the opening speech of this event, we were fortunate and privileged to have with us Mr. Benjamin Netanyahu, the Prime Minister of Israel.
Professor Balitzer and distinguished participants from around the world, thank you all for taking the time to be part of this important event. COVID-19 is a global challenge. Defeating it will require effective global cooperation, and that is why we're all here today. Only by sharing our experiences, by learning from each other, can we emerge from this crisis stronger with real answers for our peoples. I wish you all every success. Your success will be humanity's success.
Ran, can you kindly introduce Hal, who is the co-host of this conference?
Yes, let's do that. We are delighted to have with us today Hal Wolf, which is the CEO and president of HIMSS, which is probably the most important organization out there in the world dealing with IT and technology in healthcare, and actually having the largest conference that I know of globally, annually, that has the best and brightest people coming in physically. And in times before we had Corona, actually people met and were talking to each other in the same halls. So when that happened, Hal was actually in charge of having one of the largest conferences of this magnitude in the world. Is that true, Hal?
Yeah, actually it is, and thank you for the introduction. The HIMSS Global Conference is truly the largest conference in the world focused on digital health. Last year, we were poised to have over 45,000 people join us in Orlando, Florida. Obviously, we canceled the conference prior to just a week ahead of time because of the pandemic. But we're looking forward to having everyone back this coming August in 2021 in Las Vegas. So we hope by then that the pandemic will be in a much better spot and everyone can come back together to share their best practices and thought leaderships, and frankly, touch on a number of the subjects that we'll be hitting today and tomorrow in conjunction with FutureMed.
Fantastic. And I do think that we have in front of us today some of the best minds out there that will be sharing with us insights from what they went through and some foresight into what's about to be. And, you know, we have 3 sessions with us today looking at different aspects of where we were and where we're going to. We're going to touch upon in the first session on some of the crisis management experience that people have went through, leaders, political leaders, epidemiological leaders of different countries, but also business leaders looking into what they've done. And then we will have a session that's focused on technology and how technology comes to the rescue, something that you will be also speaking about today. And we will end with a look at science and how can we accelerate science in order to meet all of these challenges. So I think that you have been involved in all of these 3 in different capacities in your professional life, right? In some of these, we have crossed paths.
We really have, and have been very fortunate to be engaged in healthcare for nearly 20 years. And many of those years in operations, both from an IT point of view as a CIO and from an operations leader. And I think you hit on, Ran, a couple of critical points. One is that we've been in a system across the globe that has been pressurized because of the pandemic. And the question now is, how do we take the learnings of this pandemic, our shortcomings, our gaps, and what we did well, and turn it into a future view of where we need to take healthcare and care delivery.
And I do think that, you know, the fact that Clalit and HIMSS came together to make this event work the way it does, I think it is something that is really built into the fabric of these 2 organizations of taking insights and being in the forefront of where technology might take us on making an impact on people's lives, how technology in healthcare cannot just remain a theoretical construct or just a scientific construct, but actually bring science and the most advanced technology to the bedside and measuring the impact. And I think that actually this marriage of these 2 organizations is really, I think, classic for this type of event. What do you think?
Well, I think you're spot on. You know, HIMSS has over 80,000 members globally, and they're focused on the vision, which is to realize the full health potential of every human everywhere. And the mission lies in the goals to reform the global health ecosystem through the use of information and technology. I think what we're going to be hearing is how are people utilizing new technologies and access to information in order to take care of individuals differently than we have before. I mean, as you know, in this pandemic, we pretty much had to blow up the classic encounter-based paradigm of health. We had to create the situation where physicians, clinicians, nurse practitioners could in fact talk to people, not inside the walls of the clinic, but to accelerate areas of telehealth and digital health communications. And we had to do so quickly. And that, frankly, is not the forte of the healthcare ecosystem. It doesn't move quickly. But this time we had to. And I think what we're going to be listening for, and I'm excited to hear, are what some of those changes were. How do we keep the good ones? And how do we accelerate this change of outside in care versus our traditional methodologies of inside out?
Al, it seems that from the program that we have today, that not only we're dealing with a crisis, but we're dealing with a lot of the potential and the opportunities ahead. I think, Ran, many of the speakers here would be talking about experiments you were having at this time with data, with new IT technologies, actually to change the clinical service and the caregiving experience. What do you think, Hal? Did we see a lot of promise here that you would bring later to the medical services? And there's also some kind of a promise from this conference?
Yeah, I think it's a great question. One of the interesting facts when I've talked to healthcare leaders around the world is that we largely combated and continue to combat this particular pandemic through the use of social engineering. We've asked people to stay at home, to wear a mask, to improve hygiene, to stop social gatherings outside with groups of more than 10. So we've been using social engineering to tap down. I think the question we have is that absent of the social engineering, how do we bring those systems forward? How do we use the information, contract tracking or contact tracking, artificial intelligence, new information of monitor at home? How do we begin to deliver care outside so that when we have these types of disruptions, and we will again, we're more prepared from a population health point of view and all the way down to the care of the individual from the convenience of either their home or through a device like their phone.
And as Israel's largest healthcare organization, with all of the challenges we had to go through in the trenches of this event as it unfolded and still unfolds, actually these very days, we really saw the promise being delivered in the fact that the pandemic or the COVID-19 was the great accelerator of digital health in practice. And in many organizations worldwide, and I'm sure you've experienced it with all of the different organizations you're working with, this was one of the most effective facilitators of change that were long-standing and waiting to happen. And this event made it from a potential theoretical promise to something that everybody had to accept, implement, and put it in practice. Have you seen a lot of this happening worldwide?
We have. And in fact, one of the more interesting aspects of it is going to be how do we keep those changes and that acceleration continuing? Some healthcare systems are trying to go back to the old normal. I think that's going to be very difficult. Most healthcare systems are trying to figure out the right level of integration of the new normal, the telehealth, and the acceleration. But also, it's exposed some gaps. It's exposed some gaps in the information they have, put some pressure on our needs for greater interoperability, and to balance our risk against the opportunities that we have to really change the way that we deliver care. So, yes, I think there's a great debate going on in every single country about what can we keep. In the end, this is a massive change management challenge. And at HIMSS, we use the phrase to be the change. And we're really calling on our members and all the systems to embrace this change so that we can get the best out of a very, very difficult situation.
So many leaders listening to us today are actually now being inspired to be the change. We are definitely making the best efforts right now to be the change as we speak. And I think it is now a requisite. It's no longer just, just a nice to have. And I think that the entire world is now treading this path that until then has been walked by fairly few just spearheading organizations. So this event today that we're co-hosting together and that we turned into a reality, I think is going to leave us with so much, I think, material to work with in the coming days and months that are going to be very trying. There's no country that can feel safe that they're now, they got it figured out. They know how it's going to be done. They're there. I think that every country should learn from the experience, including our own here in Israel. I mean, we had it figured out, and then we had the challenges come and hit us right back again once we started to get life into some sort of normalcy. So I think that we all should be very attentive to the lessons learned that we're going to hear in the coming hours, and we should be prepared for the challenges awaiting for us in the coming winter, and actually even through the summer. And I think that we should be thankful to all of these bright, busy, overworked, and leading global figures that have been willing to spend time with us today and to share with us their vision, their work, and their insights. And thank you, Hal, for your friendship for many years and for the collaboration between HIMSS and Clalit that made this event happen, and really for everything that you have been doing. I want to hear from you, and before then we will begin the session.
Well, thank you again so much for giving me the opportunity to represent HIMSS and to be a part of this really important conference. I agree with you 100%. The challenges have never been larger. The opportunities have never been greater. And we have a chance in this conference to listen truly to world leaders at the healthcare level, at the government level, at agencies across the land that are really going to be able to come forward and give us important insights. So I'm looking forward to the rest of the conference. I can't wait to learn and listen. And from here in the United States, a warm shalom.
Thank you so much, and looking forward to the next conference we're going to have together, where we're going to be in the same room, because you know this is coming. So looking forward to your presentation that's going to be coming in about an hour and a half. And until then, thank you, Hal. Godspeed, and see you soon.
Thank you, Hal.
See you soon.
And now we'll introduce the co-host of the event, together with Professor Ran Balitzer, is Dr. Charles Alessi, who is the Chief Clinical Officer of HIMSS, Senior Advisor to Public Health England.
My name's Charles Alessi. I'm Chief Clinical Officer of HIMSS, and I'm delighted to be talking to you today around the response to COVID-19. But the response with a twist, because I've been looking at this really from a global perspective. HIMSS is a global organization whose vision really is to realize the full health potential of every human everywhere. And because of that reason, we're in a position where we have been invited to most nations on earth to comment on and to get involved in some of the issues to do with data and technology around the response to the COVID pandemic. So let's talk about the COVID pandemic. Of course, you know everything about it. It really is a pandemic like no other, a child of the 21st century, which largely outstripped the ability of countries to manage its effects, with some exceptions, I might add. But why is this? And I think it really is because of the fact that it is rather different to other pandemics. It's asymptomatic transmission, and also the fact that it's transmitted mainly around a respiratory, through a respiratory medium, and also through the front of the nose rather than right down into the chest. That makes an enormous difference. But anyway, what are the main factors, really, if we have to be thinking in terms of looking forward, that would determine success in managing a pandemic? And I think these factors are really, some of which are self-evident, but I'm going to give some illustrations from some countries that did things in a really remarkable way. So they are the value of a short-term memory, the value of preparation, both in terms of having the infrastructure and supplies ready, but also in terms of actually having deployed rather than theoretically having deployed. The value of real communication with a population and really taking them with you. And of course, that magic word, trust. The value of protecting your workforce. The value of managing non-COVID conditions contemporaneously. People have come a cropper, really, because all the efforts were on the COVID population rather than on the non-COVID population. The value of managing care in the community, both in terms of vulnerable groups and also in terms of care homes. And then, of course, the value of already being on a journey towards digital transformation in health and care, because you're in a far better position to deliver. better outcomes. So let's now think in terms of what does this actually mean? And I'm really going to take you around the world now. I'm going to start with the Asia Pacific and then move to Europe, because I think between those two continents, we get a sense of illustrating all these issues and what they actually mean. So let's start with Asia Pacific. And the first thing I want to talk about is Taiwan. And I say what they did was flicking a switch, because it was really quite remarkable. In 6 hours between midday or just after midday on the 31st of December to 6 p.m. on the same day, they had already set up a dedicated place within their airport for visitors coming in from Wuhan. They had already set up a dedicated taxi rank to take them to the dedicated hotels where they could have dedicated foods for 2 weeks, where they could have had an app downloaded on their mobile phone to ensure they were mobilely tethered, as well as everything else which went around it. It was remarkable. And it really was remarkable seeing a government flick a switch, because that in essence what it was. Things just happened, but why did they happen? And if there's something which is abundantly clear going around every country in the Asia Pacific and as well as the rest of the world, it's that people who have had a recent coronavirus, in other words, SARS, MERS, also H1N1, plus also some civil emergencies, events like earthquakes, or in New Zealand, the volcano exploding, where there was already a process set up which had been used recently in terms of managing emergencies. Things worked remarkably well compared to places which were stable enough not to have actually done it for a while, where memory of how things actually work may not have been as good as we thought they would have been. So I think Taiwan was fantastic in terms of flicking a switch. Let's move on. Japan. A couple of things about Japan which still really intrigue me. And I call them the enigma, because they really are an enigma when it comes to understanding how they managed, really through their really understated approach to a degree, their reverse cluster investigations, the 3 C's which they talked about around their population, crowded places, avoiding them in other words, ensuring that when they were in crowded places, they were protected. All the work they did really came to something, plus the role of government, which I compare to a midwife, because in essence, what they were doing, particularly in the beginning, is managing to get small suppliers, which they were relying on for PPE, to marry up with larger conglomerates to really deliver the capacity and capability which they needed to get the PPE they required. And the role of government there was really quite extraordinary. Let's move on. South Korea. What would you expect? Technology on steroids is the way I would describe it, with booths, with positive pressure in the community, all sorts of stuff. But there's something about South Korea which is rather special, and that's their foresight in legislation. After the MERS outbreak, the rights of the citizen were to a degree subsumed to the rights of the citizen to other citizens, which enabled them to implement track and trace technology around managing a pandemic in that way, without having to worry about the issues which concern us all in terms of personal privacy, in terms of the ability of somebody to track you. Those were suspended, and that legislation was agreed before the pandemic. So suddenly they just turned it on, and they could marry data and information from government in terms of eligibility for services, together with personal data from mobile phones, even going on and adding in data from companies associated with credit cards, financial data, and they could really manage the pandemic well. I'm not saying that's the answer for everybody, and I'm not saying that's the answer forever, but to be in a situation where you can suddenly switch it on and switch it off is really very, very good. And of course, Singapore. How can we ignore Singapore? And I really think the perfect first wave response is what comes to mind in terms of the way they approach it. Singapore has always been the big laboratory of the world, I think. This city-state of a relatively small population, but in terms of getting everything together and deploying it in real time is a wonder. Let's move to Europe now. Germany. Everybody talks about Germany, the great success. I think it's really, really laudable what the Germans have done. And you know, I am not by any stretch of the imagination saying I'm less than impressed, but they started from a very big infrastructure. We need to remember that. So they had a lot of ventilated beds, a lot of nursing, a lot of everything, a lot of testing. And so perhaps the faults that existed weren't initially obvious. Italy, completely different. Two regions, Lombardy and Veneto. In Lombardy, real disaster. They were unlucky enough to be the first place to get COVID badly, and for that reason got into all sorts of trouble associated. But next door in Veneto, they didn't admit people and ventilate them quickly. They tried to keep them at home. They tested a lot. They traced a lot, and they had a different result. Denmark, they closed down and closed down fast. They did it a week or two before, exactly a week actually, before the United Kingdom did, with the effect that they actually managed to contain that first wave substantially better. And Sweden, of course. Sweden, another of the enigmas, another of the places to watch. People say it was really not very well managed. I wonder, and I wouldn't be surprised if at the end of the day, Sweden is the place we'll look to for the future. There's no single recipe that can be applied in any way. You have to contextualize it. Of course, there are big effects of the pandemic. We're moving to a digital first situation after a long time hoping to get there. And I think this is our real opportunity. And most important, for all of us now, we need to rediscover that short-term memory, because by having that short-term memory, we'll be in a far better place, I think, to manage the next waves of this pandemic. Thank you.
Thank you very much, Dr. Charles Alessi. Ran, what do you think? Are we having a new methodology now for crisis management, public health crisis management?
No, I don't think that what we're having now is something that is absolutely new, but I do think that we have to adapt. And we've seen crises before. Every leader that Dr. Alessi has been referring to has had coped with crisis. But I think this is really unprecedented in several ways. And so we have to adapt our methodologies like was discussed. And I think that we're looking into lessons learned from different leaders in order to do that. And I think this is a great segue to speak with our next speaker. We are very fortunate to have with us today one of the most senior leaders in the world, in the realm of healthcare. And we will have with us today the regional director of the European region for the World Health Organization, Dr. Hans Kluge. So Hans, thank you so much for being with us today and the opportunity to spend time with you together. I'll start maybe with something that is really, really bothering, I think, many decision makers out there. When considering the use of digital tools and data in combating the impact of COVID-19, can you perhaps provide some reflection on the efforts of countries in the WHO European region, both in terms of successes, but also any shortcomings in their ability to leverage the value of data and digital technologies, especially in the face of the fact that Europe was one of the first regions in the world to be hit by this pandemic?
Well, first and foremost, Deran, thank you very much for having me here. You know that we have a long-standing collaboration with the Clarlit Research Institute, a WHO collaborating center. And in fact, I'm happy that you are walking the talk through this major conference, doing it digital, which is part of the new world. And this brings me to the point that WHO has been advocating for many years to strategically invest into digital health and digital health systems, be it to help transforming health systems, boosting new models of service delivery, to educate the population on the role of digital health in prevention, care and monitoring. But you're absolutely right that this whole COVID-19 response has given a tremendous boost towards scaling up in digitalizing our health systems. And we have seen many great examples throughout the regions, going from teleworking towards, in fact, keeping patients and suspect cases out of the hospitals, because we know that inside the hospitals sometimes the COVID-19 is an amplifier. But the key issue here is not to repeat the pitfalls from the past that we are aware about, mainly on the governance, the interoperability, the trust for digital health. These are key issues. And you're absolutely right that we had challenges to leverage the volume, but also the type of the data. So I would say that a lesson learned so far is that it's not only about digital health and the data as such, but the whole systems approach, what WHO has been advocating for time and again.
You've mentioned digital contact tracing utilities earlier, and I wonder if you could give us an overview of where Europe is in terms of the different solutions for digital contact tracing and your personal point of view on what is the potential of this technology for all of us in the overall context.
This, Ran, is probably one of the most frequently asked questions that I'm getting from the media, from the countries, and it's very, very topical. In fact, as of today, 27 out of 53 countries in the WHO European region have some kind of digital contact tracing solution, with 4 more lining up. And a lot of progress, but we have to be also, again, modest here, and we know that there is still no final, let's say, answer on the complete effectiveness. A number of issues come back, and no surprise. We know most of the issues. It has to do with ethics, with human rights, with privacy, and to one word. And you and me have been discussing this for many years, but it's really key again, it's the trust. And the trust issue is at the core of my vision, the European Programme of Work. Because what I would like to do with the vision for the next 5 years in the WHO European region is to help health authorities, to empower them, to help to answer to the legitimate concerns that people have toward their health authorities. And trust is what I call a biggie. And a key issue there is, I think, Ran, that we really have to come, and this is also something I have come to, let's say, to peace with myself, that there will always be a segment of the population which either is not able or not willing to share their private data with the health authorities. And let's not pinpoint and stigmatize those segments of the population, but design solutions and operational approaches which take into account those people. And if we do this in fact, I'm sitting, as you know, in Scandinavia. Scandinavia has a very strong partnership between the people who have, if you compare across the region, a very high level of trust towards their health authorities, whether it's on social distancing or digital contact tracing. So in that sense, we have to acknowledge this and work out a partnership between the health authorities, the medical, paramedical workforce, and the people.
This was, I think, a very wide-angled, advanced view of what is a truly multifaceted problem. Now, looking forward, what are some of the immediate and medium-term actions that governments and health authorities can take to accelerate the acceptance and the uptake of digital health in helping all of us to respond better to COVID-19? And we know there are very large differences in different countries in the region and in general in the world. What would your advice be to decision makers?
A lot of people are still passing away due to COVID, but a whole group of people are suffering because they do not get the treatment for a whole lot of other pandemics. A pandemic of cardiovascular disease, a pandemic of diabetes, of cancer. So there is, I think, where digital health can really make a huge impact in terms of equity and population-based impact. On the COVID-19, everyone is focused on it. I'm less worried. I'm more worried, how do we leverage digital health to decrease and avoid excess mortality? For example, how can we increase access to mental health services? Mental health is a flagship for my vision, for my mandate for the next 5 years. And this was before the COVID, but we know that we as a society will have to live with huge impacts of mental health, including consequences of the lockdown, is number one. Number two, early warning signals for other infectious diseases. we may face a second wave in the fall when COVID will meet the flu, influenza-like viruses and pneumonia. But also, let's think of how to take advantage of digital health for vaccination records and reminders, because we know that vaccination works. Still a huge question mark about COVID vaccines, but we know that vaccines for seasonal flu work. So let's take advantage also to beef up health information and decrease, right, the, let's say, what I call infodemic, the misinformation. So I would say that is something that very quickly we can make a huge impact by decreasing mortality and boosting health. My biggest concern, Ran, and you know this because you know me quite well, that social justice has been the foundation of my entire career. As a health leader, I cannot and I will not allow that we are going to have another divide. We have a social divide, and we saw it in the COVID-19, that the vulnerable people were really, in fact, hit more than the general of the population, so we cannot afford another digital divide. And that's also a big concern of the UN Secretary General. So let's work together to really safeguard, because if it's one thing that the COVID-19 has learned me, it is that no one is safe until everyone is safe. You may be a country which is doing very well on the COVID-19, your neighbor is not there. Borders, we know, cannot be closed hermetically. No one is safe until everyone is safe. So let's see this, including with digital health, as a boost to international solidarity.
You know, the problem of disinformation is a huge one. And you know there is a serious problem when healthcare becomes politicized. And this is the case right now. And it brings a whole set of new challenges to everyone. Would you be able to share with us some thoughts about how this infodemic, as you called it, what will be your recipe and your involvement? Because, you know, WHO at the bottom line is the single most trusted entity everybody's looking up for to give them the right answers at the right time and to tell them how to differentiate between true and false. But you yourself, you have to deal with the deluge of data and science. And you as a decision maker and as a leader need to make calls very quickly. So maybe on a more personal note or an organizational note, could you tell us about how the WHO is tackling the infodemic and how you personally deal with it in your day-to-day life? Because, you know, the need to read all day long and to stay updated, it's something that is difficult for all of us. So how would you tackle this?
This is absolutely true, Ran. And we get many questions also from family members, right, who question. And let me start with one issue, that science is iterative. It makes evolution. And I think that in itself is very important to communicate to the people. And it's tough, no? Also, ambassadors ask me and they expect that we have all the answers. I mean, we have a virus here, 6 months, not old, 6 months young, which is completely new. So there are many unknowns, and we have to explain this so that people don't say WHO or science at large got it wrong again, whether it is on mask or how it is being transmitted. So I think a key issue there on what I learned, because I'm under, as you know, a waterfall the whole time, is don't be defensive. And sometimes it's difficult because we all face so many pressures and we're exhausted, but let's not be defensive, right? And learn from each other. This is very important. Meanwhile, some very quick ones is that we work as a one WHO with Facebook, with Google Alerts. So we have to work also with the social media. And many of the social media outlets are very keen to work with WHO to counter this infodemic. This is very important. And again, we have to be a little bit more savvy to work with the society at large and target different segments of the population with different messages. Because WHO used to have one size fits for all. You look at the website and that's it. We cannot do this any longer. And we feel this because we had before the COVID, for example, an anti-vaccination movement. Already now, people think vaccine is going to solve everything. first we need equal access, but also, again, are the people of 40 years or 45 years going to be keen to be vaccinated? So we need to differentiate and target different segments of the population. But it's a big one. It's a huge one. And again, digital health can really help us. And WHO, and that's what I would like to do, to work with what they call champions. There are people in society that people listen to. My daughters are very polite to me, Ram, but they don't listen to me because I'm WHO, right? So, but if some stars or some sport champions are telling like this, they have a huge impact. So let's modernize and think a little bit afresh, right? To have those people who are good-willing, and there are many in the world, I see this, many people really want the best and to leave no one behind.
That was really brilliant. Really, I thank you very much for the time and also for the wonderful insights that you have shared with us. I'm sure many others will find this exceedingly helpful in making decisions in this hectic time. So thank you very much once again. It was a pleasure and a privilege.
With great pleasure, Ron. Great pleasure. I mean, you know, I follow your work very closely. You know that when you go through this, I really would like us to sit together physically or virtually to scale up our collaboration. I think I'm a strong believer in what you're doing, and we also, as a country, Israel has a lot really to show. I would like to, let's say, to go into a new era of collaboration with Israel, really.
Really looking forward to making this vision a reality, and soon enough, hopefully.
Absolutely. Thank you so much, and good luck with the conference.
Wow, what a conversation this was. And, you know, I think that this threat of infodemic is very real and very practical. And I know there has been some insinuations that some of this epidemic of news and fake news is deliberate and is driven by technology. I think that you know a lot about this topic. Nimrod, can you share with us your insights about that?
Indeed, interesting enough that the infodemic we experience now around the pandemic is somewhat similar to what we experienced in recent political campaigns, in recent political debates or discussions. And indeed, we need technology to come and help us with fighting fake news or fighting actually intentional fraudulent information. A lot of innovation in Israel is trying to tackle it by qualifying information, by ranking information sources, by trying to find out through correlations on the social graph and how people communicate around information, what information should qualify as good quality information and what information should be tagged as actually a potential malicious or fraudulent information. And I think, again, digital technologies will come to our service in fighting also this domain of information space.
So here's another space where technology comes to the rescue. And I think that the concept of information being potentially politicized, as was discussed with Dr. Kluge just now, I think one of the countries that is most, I think, entrenched in this discussion most extensively these days is actually within the United States. And therefore, we are very happy to have with us today one of the most, I think, prominent speakers to this topic globally. We have with us today Dr. Ashish Jha, the director of the Harvard Global Health Institute and one of the most prominent speakers to how the pandemic is being tackled in the United States. So, Dr. Jha, we're really looking forward to your talk.
All right, well, thank you so much for having me here. And I'm really excited to talk about the state of the virus of coronavirus in the US. And I don't actually, when I think about it, I'm not sure I'm excited to talk about it because the response in the US is going so incredibly badly. And I want to talk a little bit about why that is, how it is that we have gotten here, and what we can do to make things better. So the first case of the virus hit the US around January 20th, about the same time that South Korea saw its first case. And we could not think of two countries that have gone in more different directions. Where South Korea initially took the virus very seriously, built up an entire testing, tracing, and isolation program, and has generally managed to keep the virus suppressed. The US approach was really about denial. And in many ways, it remains about denial. So for much of January, February, into early March, the big discussion was there even any virus here? Do we even need testing? And by mid-March, it became very, very clear in the US that we were having large outbreaks in New York, in New Orleans, in other parts of the country as well. And when the hospital started getting full and the number of people started dying really spiked, we essentially went into a national shutdown. But even that was incredibly variable across states. So one of the things that's a feature of the United States is that that it often doesn't act like one country, it acts like 50 different countries, each representing a state. And especially under this president who has really tried to let states make their own decisions, all the states did this differently. So even though we had a national shutdown, the bottom line is many states didn't actually end up closing so much. We went all the way into April and May. Cases in New York and elsewhere came down. The government put out guidance of what would make it safe for states to open up. And about half the states in the country ignored all of that guidance. And around Memorial Day, the last week of May, states started opening up again. During this time, our testing capacity in the US went from close to zero to better. We were able to test 100 or 200,000 people a day. But for a country of 330 million people, that's not necessarily fantastic. Late May, what we saw was many states opening up without declining case numbers. No policies around wearing masks. And they opened up very aggressively. They opened up all the bars and restaurants, and Arizona opened up nightclubs. And really what we have now is a tale of two countries. About half to 2/3 of the states are seeing increases in cases, some of them very, very dramatically. And about 1/3 of the states are continuing to see declines in cases or very, very low flat level of cases. And it's interesting to think about why that is. I think a lot of it is really driven by perceptions among a large proportion of the American populace that this virus is trivial, that it's no worse than the flu, that it doesn't really harm people, that all the deaths that we saw in New York, they weren't even real, that maybe they were manufactured or maybe, and that misinformation campaign, I think has one of the things that has made America so different, is that large parts of the country, 20–30% of the population largely believes that this virus is not particularly lethal, not very serious, and this whole thing is overplayed. Those are people often located in certain states, often under certain types of political leaders. Though what I think is important is that majority of Americans do understand that this is a serious virus. Majority of Americans have taken the concerns very seriously. I would say there are 2 or 3 really critical things we want to be looking at. One is that we are generating about 50,000 or so new cases per day. That's what we're identifying through our testing, though much of the data says that we're still probably missing 70–80% of cases out there. So that might mean that we may have 200,000 or 300,000 new cases a day happening in the United States. That's obviously very, very substantial. The second is that mortality rates have been relatively flat, which has made some people wonder, has the virus changed? Has it become less lethal? And I have sort of 2 or 3 thoughts on this. One is we've seen a big shift in the disease from older people to young people, which of course will make the disease less lethal because we know young people are more likely to survive. Second is that we are getting better at therapies. We're getting better at treating the disease, and so even the same patient will do better. And then the third is that death is always a lagging indicator. And so what we're seeing right now in Texas and Florida and Arizona is hospitals getting pretty full and a lot of people hospitalized. What I expect, unfortunately, to see as July rolls along into August is the number of deaths beginning to really increase. And I suspect that's coming in the days and weeks ahead. Fundamentally, I think for America, we are at a very critical crossroad. We have to decide as a country, and we may not decide as a country, and I'll come back to this, but we have to make a decision as a country. Are we going to take the virus seriously? Are we going to try to suppress the levels of the virus? Or are we just going to try to learn to live with 50, 70,000 new cases a day, 1,000 people maybe dying every day? And of course, I have a very strong preference, which is I think we need to take the virus seriously and we have to suppress it. So if we were to do that, what would that look like? I believe we need a national law or mandate on wearing masks in public. Second is, I think in this moment, things like nightclubs and indoor bars and maybe even indoor restaurants may just not be tenable. And third is we've got to push more on testing and tracing and isolation as one of the key strategies. Now, this is not some magical list. This is literally the same list that countries around the world have employed. What I suspect is likely to happen in the United States is we are going to see multiple different responses to the pandemic, just as we have so far. So I suspect there may be a dozen or so states that do quite a good job and will look as good as any European country or even better in terms of all of these things: masks, social distancing, testing and tracing, keeping virus levels down, having reasonably good economic activity, maybe even being able to open schools and run schools. I worry that for large parts of the country, the politics of mandating masks, the politics of contact tracing may be such that it'll be very, very hard to do those things. So as we look on to the future, I suspect we're going to see an America where some parts of it look like Western Europe or even East Asia in terms of excellent control, and other parts that look like Brazil or Russia or other places that are just struggling to keep the virus at bay and keep their economies open.
So Ashish, would you be able to explain how would we approach the public, which is sometimes feels a little clueless with all the misinformation, disinformation, and pseudoscience and true science. And it's so hard these days to tell what's true and what's not, what's a conspiracy and what's not, what is science and what is not. So what advice would you give people when they see all the deluge of information flowing in? How can they deal with it? How can one make sense and decide for his own personal family, his own factory, his own business, what to do next? What would your advice be?
Yeah, so clear and consistent communication is always a challenge, especially when you're facing a deluge of misinformation from others. So the question is, why should people believe scientists over their friend's Facebook page? It's always, again, it's a difficult situation. I think one of the things that we are learning is while the message is important, the messenger is as well. And so in many communities, I've been advocating for partnership with faith-based organizations, with synagogues and churches and other religious institutions, so that those are trusted people in those communities. And if they hear the same message from their local rabbi or their local priest that they're hearing from the scientific community, that alignment helps counter the misinformation. But it's very challenging. And of course, there are many of us who are pressing companies like Facebook to do a much better job, because they have become the spreader of misinformation in a way that has made it very challenging for those of us in public health to just share facts and data and the truth with the American people or with people around the world.
So, Ashish, if you had to give 3 last pieces of advice to the decision makers out there watching us in what to do next in view of the coming summer wave and winter challenges, what would those be?
Yeah, so the 3 pieces of advice I would give. First is, don't ever believe that there is a difference between controlling the virus and opening up the economy. Often people see these two things as at odds with each other. The best way to open the economy is to suppress the virus. The best economic policy is a great public health policy. We've seen that over and over and over again. In country after country, people have made this mistake, and eventually they've ended up with both terrible public health and a wrecked economy. So that's kind of number 1. Number 2 is time is on our side, meaning the more we can suppress the virus and the longer we can go without large outbreaks. Therapies are getting better. We're getting closer to a vaccine. Diagnostics is getting better. So often people say, well, if a lot of people are going to get sick, why don't I just go ahead and get infected now? And the reason is because we're already much better at treating this disease than we were 3 months ago. I am confident we're going to be that much better 6 months from now than we are today. So if you have to get the virus, better to wait. And of course, we're going to move towards getting a vaccine, hopefully sometime in 2021. So that's number 2. And number 3, if you're a political leader or a business leader, the most important thing you can be doing is communicating clearly with clear expectations. We're still early in this pandemic. We are not almost done. The virus is not behind us. setting realistic expectations for people is incredibly helpful in helping them make smarter decisions, for letting businesses make better decisions, for letting governments make better decisions. One of the problems I've seen over and over again is too many people just want this behind us. Actually, we all want it behind us. But just because we want it behind us doesn't mean it is behind us. Being realistic about what's ahead of us is critical if we're going to get a hold of this virus and manage it effectively.
Thank you for this inspiring speech by Dr. Jha. And wow, that's really inspiring to think that this pandemic has also a political aspect and cultural relative approach. What do you think?
Yeah, I fully agree. And his last statement about just wanting this to be over doesn't mean that it's over is something that we also see in this country, in Israel, with the challenges that we are now facing, like many other countries that see a second wave. And I think that when we look at the pluralism of approaches, I think one country stands out, and I think that is Sweden. And therefore, we are very fortunate to have with us today probably the most important speaker for this independent policy of Sweden, and that is Dr. Anders Tegnell, the state epidemiologist and the Deputy Director General of the Public Health Agency of Sweden. And thank you so much for spending time with us today.
Thank you, Ran, very much for inviting me to this, I think, one of the very important meetings we have during these difficult times we are in right now. The COVID-19 has been hitting Sweden quite a lot, as you probably know. We have more than 80,000 detected cases so far. 2,500 people have been treated in intensive care so far, even if that number is lowering very quickly. We have more than 5,500 deaths so far. We could add that the deaths we are counting is anybody with a positive PCR for COVID-19 who died within 30 days of the diagnosis. So it's a very high coverage of death, so we don't really miss very many. And we can also compare it to the excess mortality, and we are very close to that. So there are probably fairly few cases that we actually miss. And in Sweden, like in most places, it's mainly the elderly who are the background to the mortality, especially people over 85 years of age. And it's been hitting the elderly homes, the long-term care facilities in Sweden very much. There's been a lot of discussion about seroprevalence and about herd immunity and so on. We have been trying to measure it in a number of different ways. One of our biggest tryouts, we found about 10% of the Stockholm population were immune, but measured in different areas, in different places and so on. Sometimes we measure workplaces that have 25% immunity. So it seems like the immunity is very heterogeneous. This 10% is blood donors, and in that group it's fairly low. If you look at the hospital staff, even administrative staff in a hospital, you get up about 20%. So it's rather difficult to measure, and it's been measured many times in different parts of Sweden. We get very different figures overall. So what we've been working with is a combination of binding regulations and general advice. Binding regulations includes, like in most countries, ban on visiting nursing homes, of course. Distance education for universities and secondary schools. And we banned big gatherings, first 500 and now we're down to 50 people. And we have also initiated a number of regulations for restaurants and cafes to minimize the spreads in those areas which we know is the high-risk places. And as I said, we also communicated a number of recommendations to the public to stay home when you're sick, of course. For people over 70, try to minimize their social contacts with other people as much as possible. We try to limit the travel as much as possible during a long time. And we also told people to work at home as much as possible. And that has probably had quite a great impact in Sweden, since many people already work at home now and then. And the background to this is the Communicable Disease Act in Sweden, which is most of the legal basis for doing these things. We have also a long tradition of a high level of trust between the population and the agencies. I mean, we usually mention our vaccination program as one aspect of that, where we reach 98% of the children with a completely voluntary program. So there is a lot of faith in that the agency is trying to do good things. The healthcare services adapted, I think, in a wonderful way. And at any given time, we had at least 30% of our ICU beds were empty. So there was always room for more patients. The number of ICU beds were doubled at the peak compared to what we normally have. And the public response has been fantastic, I would say. More than 80% of the people say when you ask them that they adapted their lifestyle in this new time. And the level of trust for the agency has increased. So we are at least 75% of the population say that there are high level of trust in the agency and also in healthcare institutions in general. And it's important to keep essential health services in place, not only COVID-19, but also other things, especially for normally underserved populations. And we have seen at least signals of suppressed use of health services. For example, the number of people who came to emergency wards with possible heart complaints and so on diminished quite a lot. And what impact that will have over the long term is still too early to. Now, there's been a lot of talk about that we wanted to reach herd immunity as quickly as possible. And in that way, we allowed or even maybe encourage people to get infected. But that's, of course, definitely not true. I mean, the main purpose the whole time has to be trying to get transmission as low as possible with reasonable means, and thereby having healthcare that can cope and keep on delivering high quality services to everybody. So that's been quite clear. We all know that these diseases can, even if it doesn't happen very often, can be quite dangerous to almost anybody. People often compare, or especially in the past, I think it's not so much anymore, compare COVID-19 to the flu. And of course, there are similarities, but this is by sheer impact, so many people being sick at the same time. This has a completely different impact, both on the individuals, but also on society as a whole. So I think it's a reasonable comparison to do over time, because we can learn a lot from it. But at this time, I think the message can sometimes be wrongly understood if you compare it to the flu, because this is really much worse for society, which I think most countries can tell you these days.
Knowing what we do know now, in Sweden's experience to date, which policies and practices would you leave unchanged? Which decisions that you've made in the past are you really most proud of?
I think a few things. I think one thing that was very important from the beginning was the sustainability, which I mentioned before. To have measures in place that people can live with for a long time, since we're going to have to live with this disease for a long time. I think one thing that we're very happy about that we did is to not close the schools. Because closing schools causes a lot of problems for many, many people, for the parents, because they can't go to work, for healthcare, because they're going to lose a lot of people working there because they have to stay home with their children, but not least for the children, because not being able to go to school really can have a lot of damage to children, especially children who are already vulnerable or already in a bad situation. Not being able to go to school, to get lunches at school, to be able to leave school with levels so that they can move on into other educational levels in the society is so important. And I think we're all very, very happy. Both, and I get a lot of mails from parents, I get a lot of mails from teachers and others saying how happy they are about that we kept the schools open. And as I said, we had made a comparison with Finland recently, and we cannot see that the impact of children or parents are any different in Sweden and Finland, in spite of this. Finland closed schools and we kept them open. So I think we can be quite happy about that. This does not have a negative impact, but especially in the long run, it will have a lot of positive impacts to be able to keep the schools open.
Did you change the way schools are running? Did you switch them to capsules or mandate masks? Did you just change it?
No, not masks and not capsules like that, but we gave advice to the schools to try to do as much social distancing as possible. So we said, try to avoid big gatherings. Many schools have big gatherings in the mornings. Try to arrange your school lunches, because everybody in Sweden eats lunch together to school, so that not too many people are crowding the lunch areas at the same time. Try to be outdoors whenever you can. So these kind of advice for the schools to use as much as possible depending on the local situation we're given, but not anything more stringent than that.
Which decisions that were made during the crisis in Sweden and globally we are most likely to regret?
I think we will regret closing the borders to the extent that we did. I think a lot of experience from other pandemics in the past shows very clearly that closing borders and restricting travel between countries and so on is not really very efficient, and to a certain extent also harms public health response. I mean, that was clear in West Africa during the Ebola outbreak. And I think it's also quite clear now when we're trying to open borders again. It's interesting that it seems to be really easy to close a border, but to open it up again, that is so much more difficult. And in the European Union, it changed things, I think, in a very dramatic way. We are used to open borders in the European Union. And suddenly we have regulations saying that where we can go and where we can't go in between the European countries. And I think that would be something we remember for a long time. And I think we're also going to regret it for a long time that we took these kind of measures. It's often been discussed if what we have done in Sweden can only be done in Sweden. But I think the truth is that every country will have to sort of adapt their response to the possibilities within their country. Certain things we can learn from each other, I'm sure, like schools, for example, that children are not the drivers of this pandemic like they are with flu and other diseases, that we can learn from each other. But for many things, we need to adapt them very clearly to the situation where we are. But I think another important thing is when we do that, we also need to think not only about how well we can stop the pandemic from spreading, but also what kind of are the consequences of closing down society. I think it's quite scary to hear the stories from South Africa and other countries where poor people who have a very hard time to survive in any kind of circumstances. But when you close down society, you really hit the vulnerable populations a lot more than anybody else. And I think that's something you need to take with you when you decide on doing things like that.
Wow, Dr. Tegnell, that was absolutely outstanding. Thank you for sharing so many fresh and innovative ways of looking at this crisis. I do think that we, the epidemiologists, should spend more time together sharing ideas, know-how, success stories, and also failures. So thank you once again.
What do you think, Nimor?
And you know what's interesting to me in all this session, we spoke about different approaches countries took and different methodologies. But I think one element that play a central role in all countries and how they utilize data. You know a little bit about it. All the work you've done with data and data-related innovation in Israel. How do we use data in this pandemic, and how at your organization, Clalit, who's doing a lot of work around prediction and proactive approach, where you're taking data in trying to form a policy?
So, you know, we were very fortunate to be that in this country, we had a great infrastructure to work with when trying to use data for practice in healthcare. This has not started in this pandemic. This is something that has been ongoing for at least 20 years. Back in the 90s, then the decision to make all of the digital records available and having 100% of the electronic medical record fully digital, and at Clalit, responsible for 4.5 million members, we have millions of records to look into and to use in order to improve the practice.
So how do we take, assuming that you have millions of records which are accurate and long time and tagged records, how do you take these records in order to have a better prediction in a time of an epidemic?
So you need to have some kind of a backbone. So the approach that we've been taking before the pandemic was one of what we call predictive proactive care. That means that when we look both at infectious diseases complications and especially on chronic diseases, non-communicable diseases, we also use the same approach. And it goes like this. When a person comes in with the signs and symptoms of an overt disease, usually it is fairly late in the pathological process. And at that point, it is quite difficult to have a strong impact on their outcomes. And it is so much more effective to make an impact when you come early on, when the patient is still what we call pre-symptomatic, when his symptoms and signs only begin, or when there's small changes in his lab tests and in various other information sources that tell us that he's about to have a disease. And so one of the things we tried to do over the last decade and a half is to have predictive, proactive care in practice. Let me give you one practical example. So we all know chronic kidney disease, and we know that when you have the signs and symptoms of chronic kidney disease, it is fairly late and there's very little that you can do in order to avert the consequences, maybe just delay them a little bit. So what we did is we took the data of the patients that have become patients with end-stage renal disease. And we've been able to look back 5 years and identify which characteristics are most classic for these patients that will be deteriorating. And then we have approached our patients 5 years before they were deteriorating, when they were feeling good and they were looking good. And we proactively approached them and we said, you need to come to the clinic, not because you feel bad, but because we have an indication that in the future you will have a disease and right now we can do something about it. So we did this for chronic renal disease, we did this for diabetes, we did this for cancer, we did this for heart disease, we did this to prevent stroke, we did this to prevent osteoporotic fractures. So there's been a backbone of many years of doing predictive, proactive care on the massive scale, both in primary care, but also in specialty care and in the hospitals.
But Ran, you've done marvelous job at normal times with prediction and predicting actually disease before they happen. But now I take you to February. We understand that there is a pandemic, and now you need to do it at a scale, and not on the individual level, but on a country level. How do you take tools that were utilized on an individual level and take them into a policy making or prediction at a country level?
So I think that's a classical dilemma. And let's take the example of February. At that point in time, there were very few patients in Israel that we could work with. But we did get some data coming in at that time, at the beginning from China, and then information coming in from Italy. And we had in our backbone a predictive model for influenza complications. And every winter, we identify the patients that are the highest risk of influenza complications, and we come early to them, and we try to advocate vaccines to them in a very intensive way. We took that predictive model, and we, within our team at the Clalit Research Institute, we have adapted that tool to actually fit the characteristics of those patients having complications of COVID-19 very early on, even in February. And at that point in time, when disease only started disseminating in Israel, we already had in place a predictive model for the entire population. And we identified 200,000 people that we thought that would have the highest risk of having a complication, of having some of the severe complications of COVID-19. We approached them, we contacted them, and we told them, stay home. Don't come to the clinic. Try not to leave home as much as you can, because the disease is now really disseminating. And with SMS messages and with phone calls from their physicians, we managed to keep them at home and to tell them, use our telecare services instead of our normal care. Don't come to the clinic right now.
Could you, so you call 200,000 people, which is a large volume of people, and tell them, stay home, you're at risk. But you still need to do caregiving to them. I understand that you also took some dramatic steps at care providing at home for these individuals. How do you use technology and data for providing services to individuals at home?
So one of the things that we've done, and we will talk about today in one of the sessions that we will have later, is the issue of home monitoring and hospitalization at home. And we know that pandemic is usually thought about as a disease of the hospital setting, but actually pandemic is a disease of the community setting. The vast majority of patients do not require admission, but if you do not give them proper care at the community setting, they will come in and they will flood your hospitals, and they will not allow you to have the right sufficiency and to deal with those patients. And so we created, with the help of local startups, various mechanisms for home admission and home hospitalizations and home monitoring of these patients. We have given them, and they are getting until this day, when a patient is diagnosed and he's in the risk groups, he gets a package to his doorstep with a pulse oximeter that can contact directly to one of the apps that we have, so we can follow up. And with specific directives, we also work with a local startup called Taito with a actually handheld device that allow you to do a full physical checkup from afar, and we use this both in the home setting and in the hotels that we've used in order to keep the patients quarantined. So I think this is an interesting combination. And what we were really interested to find out is that some of this had a real significant impact. You see, at the early stages of this pandemic, we were really worried about the mortality rates. But what we saw that Israel had one of the lowest mortality rates globally, even in the first wave, but also in the current wave that we are experiencing right now. And one of the reasons, now we have the actual scientific proof to that, is that a lower proportion of the elderly and at vulnerable subpopulations were inflicted and were infected as compared to the rest of the segments of society. And that actual percentage continuously decreased through the event, probably due to this predictive, proactive approaches that we've been taking.
But Ran, what can you say? You know, I try to imagine an 80 years old person that you identify them at risk, and now they are told stay at home. They get this package of some digital gadgets they never played with before, and now they are being monitored by technology. Share with me a little bit about how they adapt to technology, what the experience you had with them.
So, you know, we had our doubts at the beginning, but apparently any age group can adapt to technology as long as you do the implementation correctly and you do the proper explanation and make it be as easily understandable to the average person, and you need to have this culturally adapted, and you need to have it adapted to different languages, and of course in terms of anything, even the size of the fonts that you have are important if you want to reach some segments of society. I think that the most interesting latest point that we've been able to put in AI-driven care, and this is something that is presented for the first time here today, is something that we're putting in practice right now. And that is, we've created a predictive model for who is going to be infected by coronavirus on a personal level. We now digest data from our entire systems, data on the family members that have been afflicted by the disease, and people in the vicinity that have been inflicted by the disease, and the personal characteristics of the person and the risk that they have, a priori risk. And we combine all of this together, and every person, every day, every member of Clalit gets a score of how likely he is to be positive to COVID-19 should he be tested. And when such a person now walks into a Clalit clinic, the physician in front of him can actually see, this is something that is coming in the latest version of the electronic medical record now being introduced. The physician can see their risk. He can see that this person in front of him that comes in for a back pain is at high risk for COVID-19 because of all of these different components together. And he asked them, by any chance, have you had any respiratory symptoms in the last few days? Maybe you lost the sense of smell or taste. And so in a proactive manner, we're trying to find those patients based on a predictive model of their chances of having COVID-19.
So basically, you managed to do a personalized caregiving experience, just as we had it in digital space, but now in the physical space, based on individual risk scoring and individual data classification.
Yes, and what we're going to do next is to find out those patients who are both at high risk of COVID-19 and high risk of COVID-19 complications, and we're going to proactively send them our symptom surveys, and if they are, they have any signs and symptoms, then we do the PCR testing to them. So then we close the full circle of proactive care on COVID-19. So I think these are some points to think about on how you can actually adapt AI and data into decision-making at scale. And what I'm talking about here is not something that we do for a clinic or a hospital. This is done countrywide to over half of the Israeli population. And from the minute you do the go, then it is in practice all around the country.
Wow. Thank you so much, Ran.
Thank you.
So by that, we'll finalize the first part of our conference. As we heard in this first part, there's certainly a political aspect to COVID-19. We understand also the decision-making processes were different around the world. Yes. Different countries had different approaches, different methodologies that are tested at real time. Still, the jury is out when understanding which approach is actually a winner, and we're trying to look to data to have better predictive models. Some of them you were utilizing at a community level in Israel. And I think it's an iterative process, as we understand here in this session, where we'll go back to the data and re-examine our decision-making processes at the country level or at the community level, how to handle the pandemic. But one thing to understand from this session, we're still early in the game of understanding how to create a public policy in such a pandemic.
I fully agree, and I think what we also should remember is that this event is not a sprint, it's a marathon. And it's not about how somebody has tackled, the early stages. The question is, how do you prepare for the coming challenges? Whether you create a stable infrastructure that allows you to sustain the challenges that are about to happen, and whether you are able to learn, to have we used to talk about a learning healthcare system, and this is more of a learning response mechanism. And those countries that will be able to sustain such a learning mechanism and adapting mechanism are those that will tackle the ensuing challenges of the winter better than others. And I hope that some of the lessons learned that we've heard today is going to help us. And in the next session, we will hear more about the technology that creates the backbone for this learning healthcare system approach.
Very interesting. Thank you very much, Ran.
Thank you.
Welcome to the second part of our conference today, Innovation for the Rescue. Certainly, we see that more and more innovation is being called technology, data, AI, to help us to cope with the pandemic. Ran, so innovation would be the answer?
I think innovation is part of the answer. These are new challenges and we need new solutions. And we are fortunate to be living now and not 100 years ago when we had to deal with the Spanish flu. Nowadays, we have new armament. And we should use this armament at this time of need in the right way in order to allow us some sense of normalcy in a very, very unusual circumstances. So let's try and see how technology can help us.
Certainly, in this session, we'll see how we're using data, how we're retrofitting all technologies, whether AI could be at service at scale now. How do we use actually innovation in other fields in order to help caregiving? So now let's talk with Howard Wolf, who is the president and CEO of HIMSS, about how we use innovation and technology for the rescue.
I'm Hal Wolf, president and CEO of HIMSS. And Healthcare Information and Management Systems Society is a global nonprofit, an advisor and thought leader with over 80,000 members operating through chapters and communities across the world. At HIMSS, our mission is to realize the full health potential of every human everywhere. And it's our mission to reform the global health ecosystem through the power of information and technology. We have, in effect, pressurized the system. Our senior citizens, especially those with high chronic disease burden, are our most vulnerable population. Geographic displacement has never been under more stress. Hospitals have shut down. In many cases, clinics as well, of basic care. They're starting to reopen, but the challenges were there immediately, and we had to turn to areas like telehealth to support. Funding has recognized that we have gaps in our systems, and the consumers that are now in their home and can't reach their particular doctor or their particular environment for receiving care are demanding the use of new technologies in order to support their needs. And the growing staff shortages have never been more acute. Hospitals basically operate in 2 shifts, a 12-hour day, maybe up to 14 to 15, that is full throttle, and then an overnight where things are calm, more quiet. But during the pandemic, they've been stretched to 24 hours. And so the staff shortages that existed before, again, have really been pressurized. Digital health and health tech tools and capabilities have long recognized as providing credible support for the most of these challenges. With the pandemic and the advanced tools to date, they've really put the spotlight on the capabilities and the opportunities for digital health. Technology's role in healthcare has expanded exponentially in the last 20 years, but it hasn't kept pace with the social technology advancements of consumerism that other industries have already moved towards, whether it's finance or travel. And frankly, we've had to continue to deal with cultural barriers and sometimes protectionism, which are often to blame for the slower gains in a healthcare ecosystem. Let's never lose track of the fact that success in healthcare is always based upon three important needs: people, process, and technology. Those three must come together for us to be successful. Inside our hospitals, we have seen the most rapid adoption and advancement of digital health over the last 20 years in just the last 6 months of the pandemic. And in many cases, the adoption has been successful. The systems and the facilities that already had infrastructure in place and had gone through workforce development advancements found the transition to scale of telehealth and the use of new technologies more easy, and the ability to serve during the pandemic crisis. But many circumstances where providers were uncomfortable with the tools, they have now been faced with the situation of using telehealth where before they may have had caution. And the results are coming in. People are now used to it. Doctors, clinicians, nurse practitioners are beginning to work closely with their customers. We call them the patients, the consumers, the citizens. And so what we see now is the recognition that on a short-term basis, we have significant gains in digital health that are fulfilling the needs and the mantle of our healthcare systems. We're ready to branch out. And government funding is going to be necessary for those systems to exist behind and utilize global leadership, because if the pandemic has taught us anything, it's that innovation must be fed when the timing demands it. One of the examples that I've noted is from a close colleague of mine who works in a hospital system. They have 3 hospitals, and in 2019, they had 1,950 telehealth visits. Today, they're averaging over 2,000 per week. These are the kind of advancements that we've seen. So, what else is going on? Well, the government-coordinated efforts across the globe have focused really on, first of all, social engineering to push down on the pandemic. Stay at home, wear a mask, and manage your personal risk. But technology and information are really having their moments as well. Big data and artificial intelligence are helping to facilitate COVID-19 preparedness and responses. Countries that have mandated and maintained low COVID-19 per capita mortality rates have been sharing their strategies, and you've heard a few of them already, with more to come here at FutureMed. Early surveillance, testing, contact tracing, these are all examples of the uses of big data as well as AI. And the scale of coordination and data management required for effective implementation of these strategies in most successful countries have relied on adopting these digital technologies and integrating them into policy and care delivery operations. Again, people, process, and then the technology. At HIMSS and PCHA Alliance, we've been focusing on interoperability standards, leveraging supply chain solutions, and utilizing data reporting and expanding broadband deployment to address health disparities. Data is ultimately the key. Without it, technology and information simply cannot thrive. In our world of new technologies in the past few months, we see symptom checkers, self-triage tools or e-triage, and it's prime time for the artificial intelligence, with chatbots, for example, are being used in those e-triage and increasingly complex tasks. And finally, we're beginning to see full-fledged focus on 4 of the 5 most valued technologies in digital patient engagement: virtual care solutions, acute virtual care and EICU, patient portals, and remote patient monitoring, which has amazing upside and remains a critical link in future care and when mixed with clinical decision support. The promise of digital health and health technology industry is very strong. The pandemic has shown us that with proper data and information, We can integrate care delivery and a willingness to overcome cultural barriers. We can utilize these capabilities that have been present and drive new healthcare solutions to meet the demands of tomorrow.
Thank you so much, Hal, for this brilliant preview into the future.
So it's a pleasure to have with us Dr. Kira Radinsky, who is the chairperson and CTO of Diagnostic Robotics, and Uri Betesh, who is the founder and CEO of Datos.
Thank you.
We want to cover with you, as Ran mentioned, that the present is exciting. How innovation is entering the clinics, the hospital, and changing the way that we deliver caregiving at this time. So Kira, let's start with you. You have started an exciting company that changed the clinical triage. Could you share with us a little bit about what the company is doing and how it's becoming more relevant now at the Corona time?
So we as a company started to address healthcare loads starting from inside emergency departments. We had access to approximately 76 million visits inside emergency departments and primary care clinics. And we built an AI system that can read all of this information and then try to predict, based on answers to clinical questions, what is the probability of sending a patient to a certain diagnostic test, how urgent they are, and even reaching differential diagnosis. The concept initially was creating workflows to automate the 75% of the time of the doctor, which is not dedicated to the face-to-face meeting. We then realized that 30 to 70% of ED visits could have been handled in primary care. So we took our clinical triage system, this time for primary care, to start help navigating the patient to the correct location.
So currently in the Corona time, when many of the patients would not come to the point of care, would you take your system of the clinical triage and make it a telehealth solution?
So telehealth is just one way of talking to a doctor. But I think to actually nail this pandemic, you have to automate much more. You really need to realize whether this person needs to see a telehealth, should they be inside a hospital, or even be at home. So we started monitoring all of the population of Israel, large states in India, and even in the state of Rhode Island, all of the population, monitoring them, understanding what is their probability of having COVID based on their clinical triaging, and based on this creating epidemiological maps, explaining how the pandemic is going to look like in a few weeks from now. We then took the second step. How can we navigate them? We had access to billions of historical visits, and we predicted out of all of these patients who, if they have COVID, will deteriorate and needs to go to the hospital, and which can stay even at home. All of this helped navigate a lot of the care management protocols.
Uri, so that takes us actually to Datos and your exciting solution for the COVID-19 time, when many of us had to take the decision, if found to have COVID-19, whether we would go to the hospital or stay at home. And I understand that your solution played a significant role in the ability to have remote care automation.
So Datos is a remote care automation platform. Basically, we move care from the hospitals and the HMOs back to the home. And when the pandemic started, we worked with Clalit Health Services and the Ministry of Health here in Israel. And we put together a protocol for home hospitalization, home monitoring, to basically achieve two things. One is to protect the hospitals from the positive COVID-19 patients. And the other one is to provide care remotely to a large scale of population. And basically what the system does is we inject the protocol of the Ministry of Health into the system, and the system manages the patients automatically and provide a scoring, based on the scoring algorithm, provide a score for each one of the patients. And based on that, the physicians, the GPs, the nurses knows who to point to contact first.
Could I learn a little bit from the experience with Clalit, which I understand is now offering it to all of its patients in the home hospitalization? What lessons did you learn from this experience with Clalit at the COVID-19 time?
You know, it's very interesting because before the COVID-19, it was what we did. We provided a patient journey that basically we opt in. You had the ability to opt into that journey or to go back to the traditional care. Here in the COVID-19, there is no option. And I need to cope with Orthodox Jews. I need to cope with people that don't have smartphones or people elderly that don't know how to operate a mobile app or to go through a registration process. So we basically opened the platform, including text messages, emails, IVR, interactive voice response, in addition to the Datos app and all other things that we already do, like videos, integration to devices, data cleansing, and so forth.
Kira, I know that you as well in Israel now both did with Clalite project and with other care providers. What experience that you have with the doctors or the physicians in how they handle the data or handle the recommendations brought by the clinical triage or the automated software that you installed?
So our system was mainly predicting where COVID is going to spread. So instead of doing geo-tracking like many countries, which violates privacy, here on an anonymous basis, we created hotspots geographically around where COVID is right now. So on a daily basis, all of the HMOs and the Ministry of Health have been receiving a report telling them where COVID is right now, but most importantly, how it's going to spread. It actually started a lot of automation around this part as well, because you know where to send the COVID tests, you know where there's going to be loads. But this was perfect in the first wave. What happened after the first wave was very interesting. Less and less people started filling in the questionnaires because we were in this euphoria that everything is wonderful. And this is where we understood, just as mentioned here, is that you need some compliance from your patients to actually make this work. So in several countries in the world, they actually started making people do this, or at least making it harder not to do it. You want to go to work today, you have to fill it in, just like we're doing here in schools. You want to schedule an appointment with your doctor, you have to fill it in. And Israel will also realize that just keeping this anonymized is not serving all of the potential of those systems. Eventually, triage is something that is mapped to a person. But if we know who the person is, the company itself doesn't know who the person is, but the doctor should, because then they can call the person, they can treat them, and maybe stop the pandemic. Every 3 days that you take out of the time that these people just go outside, you've prevented a lot of the pandemic spread.
Oh, that's fascinating outcome.
I do have another we also worked in the US and quite many organizations. It's so different than what happens here in Israel. We have one accident in the US where a college implement our solution, and if you are not answering the survey, the symptom surveys, you are not allowed to access the Wi-Fi. So that's smart, right?
That's a motivation.
That's what we call nudge. Right? It's a very simple nudge.
That's an effective nudge.
It is a very effective nudge. Which I want to touch another point, Uri, actually, about something that you've said. You know, people sometimes think that the solution to getting innovation on the ground is to make it more sophisticated. But I think that it's some of the innovation that we put in practice, we did the exact opposite. So when we saw that patients do not find it trivial enough to get their, for instance, pulse oximeters connected with their devices, what was done was something very simple, right? We told them instead of doing a complex thing, just put in the numbers into the software in the most simple way, and this frugal innovation made it work. Is that correct?
Absolutely, and I think that it's all from a perspective. When you design a solution, we have to design it from the perspective of the users. And if for me to do pairing is very easy, but not for all the people in the society. But also when we think about scalability, right? In the COVID-19, you have to support a large scale of patients. Now, if I'm going to send connected devices, I need to get them back. I need to sanitize them. They cost a lot of money. So the simplest solution usually is the best.
So, Kira, in the same approach, some people really could not use online surveys, and this is where IVR comes in, right? So was IVR really important for specific subpopulations?
That's super interesting. So there's certain populations, like the Orthodox population, that they just don't answer surveys that you send them over text messages, right? So we identified those locations and had IVR call them. In certain populations, we've seen that the information coming from the digital form is very similar to the answers to the IVR, so we stopped doing the more expensive ones. But the concept is, no matter how you get the data, just get the data, and then analyze this.
I think that, fascinating, understanding of the dynamic between the patients and the digital system understanding about UI, the economics, behavioral economics. I think we could go forever. Unfortunately, we have to bring it to the end, the panel, but we would love to continue this conversation. Thank you so much.
Thank you.
Thank you once again. To me, all of this discussion about the transformation of healthcare from frontal to tele of any kind, synchronic, asynchronic, distant monitoring, there's one lingering issue that we should always think about, and that is the threat associated with cyber attacks. You know something about that, don't you, Nimrod?
Indeed. We were naive. At the beginning of the pandemic, we kind of like naively thought maybe the hackers would stop. There'll be like a ceasefire for a while because they understand that the world is suffering for pandemic. Unfortunately, hackers, and primarily, by the way, Chinese hackers, not only that they didn't stop, but they actually accelerated their activity. As we're running a practice for cyber incident response, we started getting more and more cases where clinical facilities, critical manufacturing that relates to the COVID-19, critical actually centers, telecommunication centers, which are necessary at a time of coordinating public policy and response, were all under cyber attack. So we found out that more and more hackers were either disrupting service or affecting the integrity of the data, which made it impossible to trust the data sets. And most of them had the same motivation. They were asking for ransomware. And by the way, the price for ransomware exponentially grew just as the pandemic. If we were accustomed to ransomware attacks that were asking for $10,000s to resume operation, now we've seen with factories in Europe, some essential factories in Europe, some essential clinics and hospitals, we're asking for millions of dollars.
For one
incident. So we had cases where companies that had to do with the critical services or had to do with the hospital services were asked to pay ransomware of millions of dollars. And now it's the dilemma. Would you now keep your policy that you're not negotiating with terrorists or you're not giving up to ransomware attacks, or would you save your operations? And for hospitals, as they were under attack all through 2018 and 2019, most of the time they chose to pay the ransomware. Because one thing that we learned is that the IT infrastructure in most of the hospitals and the clinics was not cyber ready. Many of the hospitals didn't even have CISOs. They didn't have basic
CISO?
Security information manager. They didn't even have basic hygiene, like data control, data encryption. Access to the data was just as easy. And the hackers even abused the remote connections to the hospitals and to the clinics to get this easy access to clinical facilities or to the hospital data sets, affect the integrity, encrypt the data and make it inaccessible to the hospital staff. And we've seen cases again and again that hospitals, clinic, or manufacturing had to deal with a cyber crisis at the time of the COVID-19 crisis.
Let me depict this. So the CEO of a large hospital or a large manufacturing company gets up in the morning, he opens his computer, or one of his chief operating officers opens the computer, and instead of seeing what he usually sees, there's a blank screen telling him, you are now under a ransomware attack. If you do not provide this amount of money within 72 hours, all of your data, your systems, your everything will be encrypted or deleted, and you will have to withhold operations for days. Don't they, all of them, have some kind of a backup plan for this? Just, shut everything down, erase everything, and restart?
And you described it beautifully. That's indeed the case. You come and you have the blue screen with this option. 72 hours, the clock is ticking. What decision you take? Most of the hospitals, unfortunately, did not have a solid, not a backup plan, but kind of like a plan of how resume operation in time of an attack. Many of them were concerned that even if data, they'll be able to go back to the data from backup system, whether it's possible that the hacker affected the integrity of the data. And now let's take a decision. You are the CEO of the hospital. Would you keep operation? Would you keep actually business as usual when data integrity may be affected? And we've seen again and again forensic teams, which are these security companies that come and investigate the matters to come with a conclusion what the scope of the attack and how you can mitigate the attack, sometimes telling the hospital it would take us a few weeks to come to a conclusive answer because you didn't have sufficient logs, you didn't have sufficient data for us to get to the conclusion. So you are now faced with a decision. You have few weeks it would take to come to a decision. What is the scope of the attack and whether data was affected or leaked? Or you can take a decision to pay now and resume operation.
That's a terrible dilemma, right? Because even if you had a plan and you have a CISO and you have practiced this, and by now that you know that if you need, you can shut it down and kind of upload additional data, there is always the lingering chance that somehow they got to your repository, they somehow changed the integrity of that data, they're threatening you, and now you need to make a very, very dangerous bet. So no wonder many of them prefer to just pay the ransom and get done with it.
And some of them, by the way, even made it public that they paid. Like the Los Angeles hospital paid $3 million. It got public a year ago. And some of them had another situation to deal with. Their patients' data started trading in the darknet.
Oh my God.
So now you're faced with the confidentiality and your patient data being traded, and you are facing a dilemma. Would I go and buy my patient's data? You are now bidding to buy back your data.
So I think I'm scared enough at this point to hold that discussion, but the take-home message for everybody involved in this is this is now a time of beyond all of the challenges. There's a great challenge of cybersecurity. If you, obviously, almost everyone have a plan. It is time to also test this plan in view of some of these questions. How do you, in real time, ascertain the integrity of the data that you've had so you can resume your operations without paying the ransomware? So this is, I think, a very important take-home message. Thank you, Nimrod, for these insights. Only a person that's been so well involved in cybersecurity all around the world at this critical time can provide us with this insight. So thank you for that.
Thank you very much, Anne.
So I think we're ready to move on to our next speaker. And we are very fortunate to have with us someone who knows the Israeli ecosystem in and out, who has been taking very a critical part in nurturing the startup nation concept and the startup nation practice. So I'm very happy to have with us today Professor Eugene Kandel, the CEO of Startup Nation Central.
When COVID arrived, we were very impressed by the speed with which Israeli startups, Israeli tech companies pivoted and started looking for ways to apply their technology to solving the problems associated with COVID, a wide variety of problems. In fact, we started creating a landscape of COVID-relevant companies, Corona-relevant companies. We even have it on Startup Nation Finder as a separate category now. And we started in March with about 70 companies. By now, there are over 250 and maybe close to 300. They're coming on board every day. This is not just window dressing. We screen those out. They come from a wide variety of disciplines, whether it's life sciences, whether it's big data, and AI, identifying all kinds of probable hotspots of infection, identifying people, what's the likelihood of them having corona based on auxiliary data, medical devices applying to completely different use cases, cybersecurity and privacy protection, mental health protection, supporting supply chains, all kinds of solutions that are helping the world to deal with this, with the disruptions associated with Corona.
Thank you, Eugene. That was interesting. I mean, what are the enablers that allow for this rapid search on technological solutions in this crisis in Israel?
Many countries had to deal with the consequences of Corona, and technology played and plays a very important role in this process. I believe that in Israel we had several features that assisted in this process. One is the smallness and connectedness of the ecosystem. That is that one of the goals that our organization is trying to reach is to connect the ecosystem closer and closer. That helps a lot, because once you have the ecosystem connected and mapped, and there is a single depository of all the startups and all their technologies, and you know them well, it's relatively easy. What remains is to collect the needs and then to bring them together. So this is something that we've been doing since the beginning of the pandemic. This is something that we've been doing for the last 7 years in much less dramatic conditions, but it's something that really worked well. Also very useful is the fact that in Israel, the healthcare system is very concentrated. Clalit, for example, is the second largest HMO in the world in one of the smaller countries in the world. So moreover, Clalit actually initiated, and another HMO initiated the creation of EMRs, electronic medical records, in the late 20th century. So we now have world's longest large-scale data, electronic data for a fairly large population, over 4.5 million people. This helps as well. And finally, we, like I said, SNC as well as other organizations created a variety of tools where companies, governments, and including, of course, Israeli government, could post their challenges, and companies could address, could find ways to address them. And so we've seen a very large demand for that from anywhere from India through Europe, Africa, and South America, and of course, United States. And this has been a very useful tool for us to connect the solutions to the challenges.
So how can we take advantage of the current challenges to actually encourage innovation?
While the current crisis represents a serious challenges today, it also represents quite a dramatic shift in the way we're going to live and interact between ourselves, as well as do our business in a variety of ways. And one of the most important ways that is going to affect the way we interact is through medical care. And digital health, which is basically bringing data and into this process of providing healthcare, whether it's in diagnosis, whether it's in providing workflows, etc., basically collecting, analyzing data, and issuing insights. And in some cases, it's actually either incorporated or combined with medical devices. And digital health is going to be the main winner, in our opinion, because not only that this is the only way for the future to deal with pandemics like that, not only it's the only way for the reduction of cost of healthcare in the developed world, because otherwise we cannot afford the linear increase in healthcare costs, but it's also the only way to make healthcare accessible to the developing world, especially in the times of such dire needs as we see now, which in developing world are much more prevalent than they are in developed world. And Israel has a very strong presence in this area. There are over 600 companies coming from a variety of technologies that have not necessarily been developed for the healthcare, but they are used in healthcare because, like we said earlier, people have pivoted when they realize that there are challenges that can be addressed with their technology. Whether it's sensors and big data and AI and anomaly detection, communications, all of these allow for very interesting solutions in digital healthcare, and strongly recommend exploring them.
Thank you so much for this, Eugene. Indeed, Startup Nation?
Indeed, Startup Nation, and exciting to see how innovation is actually emerging at a time of crisis. Another interesting phenomenon about Israeli innovation is how we take the defense sector, which was very innovative, and industrialize or civilize some of these technologies for civil users. Our next speaker is Dr. Daniel Gold, who is known in Israel for the Iron Dome, the solution that we have against missiles. And now he's the head of the Israeli Defense Research and Development and leading innovation at a corona time, taking defense sector technology into fighting the pandemic. Let's see that. Dr. Danny Gold.
Hello to all. It is my pleasure and honor to be here. I will talk about 2 or 3 main issues. One is what my organization is doing day to day. And another subject will be how we help the country to fight the coronavirus, and another how we work with the civilian world. So starting a little bit few details about my organization. We in charge of research and development for Ministry of Defense and other defense agency. We are doing research and developing the technological building blocks and system for a wide range of application, air, land, sea, intelligence, cyber, command, control. So we enhance the scientific and technology knowledge in Israel, reaching superiority in technology. In addition to that, we have more mission like we are training, selecting, training, screening the elite personnel in high school, select them to the top technology leaders, draft them to the army. They're supposed to be the top technology leaders of Israel for the future. And the fourth one is we're in charge also of international cooperation regarding research and development and technology. This is more or less what my organization is doing. In recent years, we are working very closely with the commercial market, with the civilian market, because the market is boosting up out there with various technology which can be dual use. Dual use, you can use them in the variation in the commercial world and variation in the defense world. One, of course, is artificial intelligence and big data, connectivity, communication, Internet of Things, of course, 5G, new space. I will show you some movies, what we are doing by examples. This, for example, is almost self-own protection system that protects tanks against anti-tank missiles that shoot at us. You can see through intersection. This is a new autonomous fighting vehicles, new generation of vehicle. You can see inside the 3D augmented reality and all based artificial intelligence. This is our vision to use laser to intercept incoming rockets and missiles to create dome around the cities, around the formation, that everything that want to hit us will be targeted and burned by a laser. And this is, of course, the Iron Dome. This is a real operational results, intercepting 15 Hamas rockets, our enemy rockets above Beersheba during a ceremony. In the coronavirus, what I did after being in the Prime Minister's office for some out of the box thinking what to do with this crisis, we take almost all the capability that we have in the defense establishment. Capability is, of course, the human resources. I have many experts in many fields, devoted, know how to work, from research and development to produce the solution and assimilation in the field. And we put everyone into the game. We work together with my people, of course, university, research center, defense company, commercial company, startups all over the country, and we try to help. We send our people to the hospital, to the corona department, to the Kupot Cholim, to the Ministry of Health, understand what they need. We sit together and do brainstorming, and immediately went to a search for solution or create a solution. Again, from protection and reuse of equipment, remote sensing, standoff remote sensing. I will show some example later, using our own capability and AI software, and of course the famous production ventilators shortage of supply. What we have done, we implied our formal process that we do in the defense forces, but also a formal process. Instead of getting operational requirement or let us say exposed hidden need, we went again to the hospital and revealed their needs and analyzed the problem. Studies very fast. Some of the issues, of course, many of the issues have never been known to us ever. We are in the defense world, technology world, and we went to develop the solution. I can divide our effort, which is a massive effort, and I think it's the first time ever that we deviate our ship very fast to deal with the medical problems. And as far as I know, it has never been done anywhere around the world. I can divide it into 3 sections. In the left section, we see a life-saving technology. life-saving technology. The famous one is, of course, ventilators. There's a shortage of supply on ventilators. We can buy, of course, around the world from suppliers, but nobody sells to you because each country keep their stock for itself. There's a massive shortage in ventilators, and we are prepared to the big boom, thousands of people who will need ventilators. So I decided to take some small company, commercial company that have the knowledge or the supply in very small numbers, the ventilators, attached to each one of them, big defense company, like Israeli aircraft industry, they produce missiles and satellite, attach them together in order to ramp the production line using the capability of the defense company, and also ensuring the supply chain. Supply chain is all the elements you have to buy in order to assemble this ventilator, the supply chain. And now we have three companies. Each one is attached to a big defense company. They're all devoted to the mission. And we have a secure supply chain, which even now producing the ventilators. So we develop technology that you can sense the measures of the patient from standoff, from few meters away. You don't have to come close. Using laser or infrared or even radar. We take from the defense world the radar, and you can measure the measures from standoff. B, we connected all the elements from ventilators to monitors to a central location. We digitized everything. And C, which was a massive effort, we connect all the hospitals in Israel to one center that you can see everything. What is the situation of the patient in this hospital? You can go down to the certain patient and see the measure, how many ventilators we have, how many beds we have, what is the condition of the teams. Everything is controlled. We did it in few weeks, which is normally take 5 years. In few weeks, we put into the game more than 100 programmers and analysts to do it. So this is, let us say, preparing for the wave and activated, efficient, and in optimal manner. And the third group, which is very, very important, I call it game changer. Game changer is concentrated around test. Massive, fast, and reliable tests. Tests today, the regular PCR take you to do it depends where, between 5 to 7 hours or 8 hours. Only the test, the biological chemical test. You add the logistic from test to result can take you a few days, depends how much you're efficient. We want to create technology that you take the test and you get the result in 30 seconds immediately. And then you can open the economy, open the airports, you can act very fast. I want to reach to 100,000 tests a day. I give you some example showing some movies. What we have done is already, of course, activated. Here we can see a breath analyzer. You breathe 3 times to some tube. We take the tube to some machine, electronic machine. The machine gives you a result in 30 seconds. It radiates some electromagnetic radiation. We deviate this technology from defense to this area. This is another technology. You breathe again. You breathe to your breath, and then you put it in a small machine that smells the virus, and you get the solution again from few tenths of seconds. Most of the technology, some already assimilated in the field, in the hospitals. Some we are still testing them, passing for all the chain, of course, Helsinki committee, and getting thousands of patients to prove that the system can work. Adding layers of artificial intelligence, machine learning, because the system is learning all the time when you give them more and more patients. So I hope soon will be some activation in the field on authorization, Israeli FDA or American FDA, for the game changers. I think there are much more examples. The main issue is to take the creativity, the capability of work in uncertainty, to devote themselves to the target. This is our people. I mean, my organization and 1,000 people out of my organization, and working together to achieve the mission. Thank you very much.
Thank you, Dr. Danny Gold. Indeed inspiring, taking innovation from the defense sector and helping, at the time of crisis, the health industry. let's see how we do it in practice. Rafael, Israel's third largest defense contractor, at real time, seed innovation.
Indeed, and I think what we will see later on in one of the coming sessions, and this is just a promo, we are going to see how they have created a respirator out of really de novo approaches and allowed, in this case, allowed one respirator to treat more than one patient. And I think this type of frugal innovation is something that is very interesting. We'll not go into it now, but in the fourth session, we'll see more of that. So let's go back to our plan.
Yeah, and in Israel, something which is unique, we have the Israel Innovation Authority. It's a governmental authority dedicated to support and help startup innovation. So it's, for me, a pleasure to invite Dr. Anya Eldan, who is the Vice President of the Startup Division at the Israel Innovation Authority.
Thank you, Nimrod. Bioconvergence is the future of health tech. We're going to talk today how bioconvergence is going to create a future growth engine in Israeli economy. Israel Innovation Authority is a government agency entrusted with investing in innovation to promote sustainable and inclusive growth. And we do that through three pillars: enhancing the innovation ecosystem, enhancing economic impact of innovation, and enabling disruptive emerging technology, which is what bioconvergence is all about. Bioconvergence is roughly anything that integrates biology with physics, biology and AI, biology and nanomaterials, multidisciplinary approach to create the future of health tech. Following the outbreak of the COVID-19 pandemic, we can see that bioconvergence is making an important contribution in every stage of the preparedness to the pandemic. So in the short term, we have seen wearable sensors, we have seen paper-based synthetic diagnostics. In the midterm, we see a lot of command and control software that helps identify the pandemic and help work together between health and economy. And long term, we see all the development of vaccines, development on fast diagnostic, development on therapies. All of that and a lot of that can be based on bioconvergence and convergence of technologies. For example, an Israeli startup called Barcode Diagnostic that created a very exciting bioconvergence technology for personalization of cancer treatment, were able to use the same platform to create mass diagnosis of COVID-19 patients. And there are many examples like that. We think that Israel is in a unique position to become one of the leading clusters in bioconvergence sphere. And I will explain why. Israel is a very, very multidisciplinary industry. We have very strong successes in medtech industry. All the large medtech players are based in Israel. We have very successful and very rich life sciences research. AI capability in Israel is world-renowned. Israel, in fact, is the third largest AI cluster in the world in absolute terms. And the government has invested substantially in enabling technology, both in the digital health initiative of about $300 million and the nanomaterials initiative in which we invested even larger amounts. So all of those together, we think, can create a bioconvergence ecosystem that's going to be one of the first movers. Some examples of bioconvergence: bioengineered nanorobotics, therapeutic discovery, 3D printing of tissues, optogenetic therapeutics. There are many different areas. And the important fact is that not only there are world-leading researchers in Israeli academy, but new startups are spawning as we speak, creating those breakthrough companies. And the three key pillars for building the national strategy in bioconvergence are research. Research is the most important part because most of the innovation in bioconvergence is going to come from academic institutions. So our goal to enhance the bioconvergence, the transdisciplinary research, our goal is to create partnerships between local researchers and researchers worldwide, and to create transdisciplinary education programs. The second pillar is industry. Israeli industry has been developing very rapidly around bioconvergence. We've created over 50 companies just this year. For our COVID-19 call for proposals, which we did on April 1st, we received 900 proposals within 2 weeks, most of them from the industry, about 100 from researchers. So the interesting thing about bioconvergence is that you can very quickly move from one application to another, as we've seen in the COVID-19. And the last pillar, which is very important for us, is global collaboration. We understand that Israel will not be alone in making this transformation. We need global alliances, we need collaboration. Israel has been blessed with hundreds of R&D centers by multinational companies based here who have contributed tremendously to our success, and we invite a lot of other players, pharma companies, medtech companies, to come and join us in this exciting health tech revolution.
Thank you, Ani Eldan. Indeed, inspiring approach and inspiring vision for the future.
I think yes, and it is a good time to move from the vision to the very practical challenges that countries are facing and how technology can help them. And we are fortunate to have with us Matthew Gould, which is the CEO of NHSX, a joint unit between the Department of Health and Social Care and NHS England that was set up to ensure that staff and patients have the technology that they need, and how their division have coped with the COVID challenges and some of his views. So let's talk right now with Matthew.
Well, first of all, it's really nice to see you, Rand, and thank you for inviting me. The last few months have, I think, shown the value of technology, digital technology in healthcare, and given a massive boost to the digital transformation agenda across the NHS in the UK. And I'll pick out a few areas where technology has made a big difference. Not necessarily very advanced technology. In some cases, technology which has been well used in other sectors for some time, but not used in healthcare. So one is remote consultations. We moved very quickly when the pandemic hit to move the vast majority of appointments, both at primary and secondary, to a remote basis, either on the phone or online. And that's been extremely effective and very fast. Primary care, 99% of general practice surgeries now have the ability to do online consultations, and a significant majority of consultations are remote, whether that's telephone or video. Now, I suspect that after the pandemic, there'll be some balancing. We won't necessarily stick where we are. We won't go back to where we were before. We'll find a medium between the two. But the key thing is now the principle that actually care can be delivered remotely in a lot of cases and for a lot of patients has been established and will be more easily accepted both on the clinician side and also on the citizen side. So that would be number one. I think number two would be the use of data, where we realized that to manage the crisis effectively, we would need to have really good aggregated anonymous data for managers at national, regional and local level. So we set up the NHS data store with all sorts of protections in place, and it put the management of the pandemic on a totally different basis. And then the third area is it's given us a real push, both because of the necessity of the moment, but also because of some of the emergency regulations that came with the pandemic, to sharing patient data. So we've been able to get patient data flowing more, safely, but more effectively around the system so that clinicians can more easily access the information they need about the patients in front of them. And I think between those three things, I think a big difference has been made.
You mentioned use of data. Now, how is data used in order to promote better care during the pandemic? Can you give us an example?
So I'll give you a couple of examples. At national level, we were able to track quite effectively capacity against demand across the system. So we knew where there were spare beds and what sorts of beds, whether they were ventilated beds or whatever. We knew where there was a requirement or shortages of different sorts of supplies. And so we were able more effectively than we would have been without this quality of data to manage the flow of supplies to where they were most needed. In terms of individual patients, with the agreement of our various sort of medical associations, the British Medical Association, the Royal College of GPs, we added more data about patients to what we call the summary care record, which means that if you were a paramedic meeting someone for the first time, or somebody presented at hospital who you didn't know, you could look at more pertinent details about their clinical history than you would have been able to otherwise. And we know that this has saved lives.
That's very significant. Would you say that AI, artificial intelligence, with all the hype, has actually delivered its promise up until now?
I think it has in certain respects. So in terms of extracting insight and understanding from huge quantities of data, we've seen, I mean, real progress made on our understanding of the data on how the virus affects different groups of people, different cohorts, through the use of AI and sort of advanced data techniques. I think where it hasn't yet had the impact that it might have done has been as an intermediary between the clinician and the citizen. But I think that's probably a function of our the stage of our understanding of the virus. And as that understanding grows, the ability of AI to provide a sort of smart triage tool, I think, will grow as well. So its moment for that may come as well.
There's a claim, Matthew, that COVID-19 was an exceedingly effective accelerator of digital health adoption, maybe the most effective one ever. And you've mentioned some aspects of this earlier on when you talked about the adoption of online care and alluded to some of the symptom checkers. Could you tell us a little bit more about your experience in the UK and which digital health transformation aspects were accelerated during COVID-19? And what actually changed that allowed it? Was it regulation that changed? Was it acceptance by the physicians and by the unions that changed? Or maybe it was acceptance by the patients or just bare necessity?
One of the things we did early in the crisis that I think made a massive difference was we produced a really simple one-page guide to information governance for people working in health and care, saying essentially, if you are in good faith, trying to look after your patients and acting in sensible ways, then you're not going to get into trouble. And that was endorsed by our information commissioner, by the National Data Guardian, and it had a really positive effect because it sent a signal, look, just be sensible, do the right thing, don't get yourself caught up in knots over sort of the massive detail of law, but just get on with it. And that was extremely positive. And we need to capture that can-do spirit and sort of bottle it and keep it for the future.
That's really a beautiful way to end this interview, Matthew. It was brilliant as always. This was very enlightening and very helpful. I think there are many, many new ideas here that others can use and emulate. I know how busy you are these days, and I want to thank you again for taking the time and spending it with us all. I'm sure that many people will benefit from it, so thank you.
Thanks, Ran. It's great to see you, and I'm sure you're one of the few people who's busier than I am.
Thank you so much, Matthew. And we fondly remember the fact that you were also the ambassador to Israel just a few years ago, and Godspeed with your current challenges. So, Nimrod.
Indeed. One can remember Matthew was leading the cybersecurity back then when he was the ambassador to Israel. We had a lot of inspiring conversations with him about innovation. And now let's see how in Israel, the Ministry of Health is actually dealing with some of the challenges that we are facing, contact tracing and the use of technologies in order to help us control the pandemic. So it's my pleasure to invite Rona Kaiser, who is leading the Ministry of Health Information Technology Division.
In early February, we understood that we are up against a new pandemic. We didn't know what it is. Is it the Spanish pandemic? Is it SARS? Is it something else? The only thing Israel did know that it is reaching it very quickly, and that we had to control the pandemic and the infection ratio. So what do you do when you have pandemic in your hands? Obviously, the strategies are similar to other pandemics. First, we have to trace the infected person. Then we have to understand where he's been in the last 2 weeks. Now, I don't know what about you, but I don't even remember what I did last night. So asking me where I've been in the last 2 weeks would be very hard to remember. After that, we also need to understand who he's been in contact with, close contact, 2 meters for up than 15 minutes, and that's a hard task. And then we have to make sure that those who were in contact with him go into quarantine and get protected. So obviously the problem was first, track those who you were in contact with, then quickly notify them, and last, get them into quarantine. And this is obviously something that needs to be addressed by technology. And the solution was obvious. Mobile technology was the most matured one. But you know, mobile technology also has limitations, such as accuracy. We have to make sure that we know how far you've been, who you've been in contact with, for how long you've been in contact with. Also, there's a privacy matter. We don't want people to know where we've been, or for how long, who we've met. And you know, at the end of the day, I don't want people to trace my actions during the day. So privacy is also important. There also are other limitations, such as population that do not have smartphones. And what about if a mother gave her phone to her son? What about if I forgot it at home? So we did have to find out how to deal with these limitations, or at least acknowledge them. Also, technology was not the only thing we had to take into account. You know, when you come into close encounter with a pandemic, or pandemic in general causes panic, fear, and stress. And we needed to address this psychological issue of human behavior, the need for control, the need for certainty. So when taking all of this into consideration, we came out with 5 core values. First of all, quickness. We needed to stop the chain of infection quickly. So we needed to make sure that people get notified very quickly and understand how to go into quarantine as quickly as possible. Solidarity. It is very important to understand that this war, let's say, is not my war or your war. The solution is based on us understanding that we are a part of a community. And as long as we keep ourselves safe, we keep the community safe. So solidarity was a very important value. Also, simplicity. We wanted to make sure that the app would be very simple. The solution would be simple to understand. Reliability. We talked about it. We have to make sure that we are very accurate. We need to make the public be able to rely on the solution. And last but not least, trust. Everything is based on trust. And the government bringing up a solution, an app, which is talking about contact tracing, I must say that trust is a very interesting issue. So how did we do it? First of all, we talked about how quickly we get you into action. How do we do it? We integrated in this app simple call to action buttons. The information is very simple. You don't have to read a lot. The language is clear in order for you to understand what is needed of you and how you actually go through the motion. Designed for simplicity. Everything about this app is simple. We wanted to make sure that even if you are not a tech frenzy, you will know how to act and when to act upon. So simple screens, simple messages, simple language, simple instructions for you to follow and go into quarantine immediately. Manage for reliability. We wanted to make sure that the app is as accurate as possible. Now, this is something we are still struggling on because it isn't simple. It isn't simple around the world, and it isn't simple here in Israel. But we do have hope because we hope to launch very soon a new version of the app, which is not only based on GPS and location technology, but is also based on Bluetooth technology, which enables us to be more accurate. We also have the call center ready for you to call, and we also still have and will always have the staff pandemic investigation. And last but not least, I think it's the most important one, is the balance between the protecting of lives, the need to protect lives, and the need to protect our privacy. And I think this is something that was core value in the planning of how the app would work. We needed to find the optimal balance between that. And how did we do that? First of all, it's an opt-in of everything, opt-in app. You have to agree, you have to download it, it's voluntarily. Secondly, the architecture. The architecture is one that all the information stays in your device. The only way to share this information with the Ministry of Health is by accepting the share and not having you, and it doesn't mean that you have to share it. We have no knowledge of where you've been, if you got notified, if you got into quarantine, but we want to work on that trust. And for that, we also used open source platform. So everybody could see what we're doing. Nothing is in the dark. You can see everything. But the main important is that you have the control. You can decide what and when you want to do. But you also have the responsibility for your life and for the others. And that's an important key to make us work together in trust. Thank you.
Thank you, Rona. Ran, that brings to an end our second session about how technology came to the rescue at COVID-19. And indeed, I think we've seen some inspiring innovation and some exciting startup taking the technology, adapting it to the COVID-19 challenges, and helping at a time of crisis in providing telehealth, AI for prediction, a lot of technologies of bioconvergence, taking innovation from other domains and leading them into the hospitals and the clinical care.
Yes, and I think beyond that type of convergence, we've also seen unique types of collaboration. We've seen the startups in the private sector, and we've seen the Ministry of Health in the public sector, and we've seen some innovation coming from the military and security sectors, and all of these people working together at a single point in time, trying to make things work in a situation that is unparalleled. And I think that gives us a lot of hope to the future and could lead us towards the next session.
Indeed, being part of the ecosystem, you see how everybody is working together, public sector, private sector, startups, investors, all trying to come up with some solutions for current needs. Indeed, inspiring session.
Thank you so much.
And that leads us to the third session of the day. Third session of the day would deal with how we accelerate science.
Indeed, we will have the chance to speak with some leading scientists, with some of the world's largest pharma companies and their top executives talking about some of their challenges and their aspirations for the near future with some breaking news. I think it will be interesting for all of us. And we will also, I think, hear from the editors of the leading journals of the world, the New England Journal of Medicine and Nature Medicine, about how accelerating science and how to deal with some of the burden that this leads to the scientific publication industry. So this will be exciting to all.
What exciting and accelerating science is that there are some good science and bad science, and how you differentiate between the two at a time of a pandemic. And I think a lot of what we'll see here is how you adapt methodologies, both for drug development, regulation, keeping privacies and other values which are important at development, and keeping them in the same quality, but when you still accelerate the processes and try to come up with results at a time of need.
Indeed, challenges of acceleration. So, see you in the next session.
So welcome to our third session. In this session, we'll talk about how we accelerate science and what the challenges in accelerating science. Dan?
Indeed. So I think this is a critical point in time where we have to get new discoveries done in a more rapid pace than any other time in recent history. And the need for speed is great. And the entire world is looking at its scientists, its doctors, its innovators in trying to get a remedy to this grave situation and to get it now. But there's a limit to how much you can accelerate science. And if there's one person in the world that stands in that specific point where all of the expectations and pressure is pinpointed at, is our next speaker, which is the editor of the New England Journal of Medicine, Dr. Eric Rubin. So, Eric, thank you so much again for taking the time and spending it with us today. You have the privilege to be exposed to the most exciting science out there in near real time. Especially at this time, this is something really precious. And the world is struggling to cope with the pandemic. And 6 months into this odyssey, it seems so little was achieved in terms of science as compared to what we could have expected maybe 6 months ago. So at least what I was expecting to see was much greater than what we have right now. So from everything that you've read and seen, could you please provide us with the best nuggets of the new helpful insights, how to cope with this emerging challenge?
So among the interesting things that I've seen that we haven't been able to publish are a lot of hypotheticals. Here are things that we should be doing. It's not the kind of thing that we do, but there are still a lot of good ideas out there that are waiting to be tested. I think one of the challenges, and you talked about the pace of a change, one of the challenges is to figure out how to do rigorous testing of ideas in this moving environment. So that's one category. Another is institutional responses. Our hospital, our emergency room, our healthcare system has suffered because of this, and this is what we're doing to deal with it. Here's how we're trying to prevent infection in our clinic. Here's how we are still able to do important cancer surgeries despite the threat of infection for patients and for our staff. And I think those are interesting. They're very interesting experiences. I think people can learn from them. They're not tests, and that's the kind of thing that we publish. But I think that there is a lot of value in people thinking about the epidemic and what kinds of things we can be doing.
I'd like to move on to something that is more specific to your day job, which is how your journal coped with the immense pressure to provide rapid cycle decisions on early stage scientific evidence that has, unprecedented potentially impact on global response to the pandemic. So how did you handle this?
As a doctor, having been on during COVID-19, I can say it was very frustrating early on to not have any guidance whatsoever. And I think we didn't want to be purists about it. We wanted to get information out there that could be useful. And that meant that we have published things that perhaps under ordinary circumstances we wouldn't have, but it's just such an urgent situation that we felt like it was important. And I don't feel badly about that at all. We've moved on, I think, to more to our sweet spot of randomized controlled trials as they're appearing and less experiences and retrospective studies. But I still think we learned quite important information from those studies. Getting back to process though, we haven't really changed anything. We still get a large number of peer reviews for the most important articles. We still have the same editorial process with a back and forth with the authors. We just have accelerated things tremendously. That means a couple of things. That means that there's a lot of stress on our staff. And there are a lot of late nights and weekends, not just for our editors, but our editorial staff. And I'm really proud of the job that they've done. It's really amazing. They've really stepped up in a big way. It means that people have taken on things that are outside of their expertise and had to handle them. It's a huge stress on reviewers because the reviewers we ask are the same people who are taking care of patients and setting policies for their hospitals or their government institutions. And people have been very forthcoming and really stepped up in that respect.
It is possible, even in the way the reviews are currently being structured, is it even possible to do such a rapid cycle and still deal with issues like fraud that are never easy to deal with, but especially now when everything is basically burning?
Fraud is a particular issue. It's an issue all the time. And would we be less susceptible to it if we took more time? I doubt it. The specific incident that you're referring to is the retraction of the data from Surgisphere that we had to do. We don't know if it was fraud, but it certainly was unreliable, unsupported data, at the very least. I think that we got all of our reviews, and after all the review process, after we published, we didn't actually get any letters to the editor that suggested that it was fraudulent until the Lancet study was published several weeks later, and it became clear. It wasn't so clear from what we published and from the data that we had. We're not that set up for fraud, though. I mean, we're susceptible to it. We've published other fraudulent stuff in the past, as has every scientific publication. And there's a level of trust that we have and our peer reviewers have in our authors. So, and I think that we are making changes in response to what happened, but I don't think that it will never happen again. At the time we published that, we also published 2 other articles which drew the same conclusion from independent data sets. And so we think the conclusion was right and that we weren't likely to do harm by publishing it. We have rejected several manuscripts where we think that we felt that the quality wasn't so bad, but it wasn't good enough to make the claim that we'd end up making. So it wasn't really a knock on the study. It was our concern that our publishing it would put this imprimatur that would allow people to use a therapy. So I think in the end, we get to take fewer chances than other journals, but that means we have to be that much more careful.
I think that's what happens when you are the one who's basically setting the standards. But in any way, you have been running business during this event. What are the most proud moments you have to share with us in the way the journal has been running during this event? What would you have done differently now, in perfect hindsight?
What I'm most proud of are people. I think this is really about what individuals do. Our journal is very focused on our editors, our editorial staff, our reviewers being willing to put in the time and be proactive. We go out looking for articles all the time. We solicit many of the things that you've seen are solicited, not just the studies, but opinion pieces about how to reopen the economy. What is the interaction between racism, which is a very big issue right now in the U.S., and the COVID-19 outbreak? Those sorts of things we have relied on our editors, and then ultimately authors being willing to submit to us. So I think we've done well. That retraction notwithstanding, I think we've published much of the important work in the area, and we've helped make it better, I think, through the editorial process. I think we probably would have moved to some of the systems that we're using now earlier on. We have a more efficient way of screening articles. I'm very sensitive to it because I'm the screener, and it's when the volume was over 200 a day, it was taking up most of my day just to read through all the submissions. Now both the volume is lower, and we've come up with a much more efficient way of getting through all of that. It's still me, but at least it doesn't take clicking on a mouse over and over and over again like it used to. I certainly look forward to the day that we can get back to normal and look back on this to see what the lessons were. Already we've been experimenting with new forms during the pandemic, and I think some of those are going to survive, and I hope that we can get an idea of what works and what doesn't. What I say about our journal, I think, goes for all journals. Everyone has had to innovate, I think, and they've done it in different ways, and I hope that we not only learn from what we've done, but from what our colleagues have done at other journals.
Thank you so much, Dr. Rubin. That was very inspiring, wasn't it?
Indeed. How can one meet the challenge of both accelerating science and publication of good science and at the same time to confront fraud and bad science? It seems a real challenge.
No, I do agree. And I'd like to have someone's take on this. We have with us still Dr. Ashish Jha, and I'd like to hear your take, Dr. Jha, about this same challenge that we've been discussing. How do we deal with accelerating science and preventing bad science and scientific fraud? So what's your take on that?
Yeah, so I think what's really important as we think about those scandals from the company Surgisphere, for instance, which I guess is now no longer even exists, is we have to do two things. First, I think we have to understand that in a pandemic where we're generating so much evidence and so much data, that not everything will work perfectly and you'll get a few missteps. So on that level, I'm not that upset about it. But for those major journals, the Lancet, New England Journal, other journals, they've got to keep their quality control in check, because it's one thing for a preprint server paper to end up being false or problematic. It's another when the premier journals of the world end up publishing things that end up being problematic. And that really does mean maintaining their peer review, getting a lot more input, especially when the findings are blockbuster or they're counterintuitive or they seem too good to be true. Really applying a level of skepticism. I think journals want to be the first out because there's so much news cycle around all of this, but it's got to get weighed against the fact that they've got to get this stuff as right as possible, knowing that no one's going to do it perfectly, but they could do a lot better than they have.
Thank you so much, Dr. Jha, for this intervention. Very valuable. And I think we're now at the perfect point in time to move to our next speaker. We have the pleasure and the privilege to have with us Dr. Joao Monteiro, the editor-in-chief of Nature Medicine.
Thanks for having me.
Joao, I was wondering, since you are privileged to see some of the most interesting scientific work being done pretty much anywhere around the world, lots of it coming your way, could you share with us some of the more interesting things that we might not be able to read in your journal because it was whipped out or because it is something you read elsewhere? What can you share with us today?
Yeah, I think that that's probably a very challenging question because there's just so much information coming out very quickly. I can tell you that some of the things that we are most excited about or that we would like to be hearing more about and understanding better is really, whether we can develop a protective immunity against the new coronavirus and how we can measure that type of immunity. This will be very important as we move forward with vaccine development and we understand what we have actually to be looking for in the people we are vaccinating in this first wave of trials as a measure of whether they will develop a protective immunity and what that type of immunity would look like. So I would say right now we're very interested and we're seeing a lot of new insights into the immune response against the coronavirus. Some, I would say, a little concerning new data suggesting that it is possible that for people who do not develop a very strong infection or develop an asymptomatic infection by the virus, that immunity might be short lasting. But I think that we need more data in order to understand this problem better.
So you're standing as a journal really in the border between basic sciences and the practice of medicine, and you really have to choose where those two worlds come together. In view of the recent challenges, have you been considering perhaps because of this event having more papers on the practical side as compared to the past?
Yeah, definitely. I think we had to adapt our editorial criteria to cope with the needs of the pandemic. In the very beginning, we really didn't know anything about this new virus or what the disease looked like or how we should be responding from a public health perspective. So we did adapt our criteria to identify research that we felt was most urgent to be surfaced and to be vetted by specialists and that needed to be made available to our readers in a peer-reviewed form very quickly. As the pandemic moves forward and we have more and more information coming out, of course, our criteria for what we consider, scientific, a new scientific development also changes. And, we moved from just understanding the very basics to looking for work that's more robust, that is looking at larger populations of patients and how they respond to the virus or how the disease manifests in these people, how we can understand whether people will develop a very severe disease or not. So I think our editorial criteria, it significantly changed in order to be able to cope with the needs of the pandemic, and it's constantly evolving as we accumulate new knowledge.
Is there any specific type of domain that you would be most interested in the coming future to see more papers or suggested papers coming in your way?
Yeah, I think there's so many gaps still in our understanding of what's happening in this pandemic. We are, as a journal, very interested in some aspects of how you manage the pandemic from a public health perspective, of what kind of new technologies can help us to understand how the virus will spread, how you can predict ahead of time whether there will be new hotspots of viruses, how we can stop transmission chains. I think we are beginning to make movements towards that direction, but a lot more is still needed to be able to effectively control the virus.
I see. I'm sure that this period has been challenging for you both on, as usual, the personal, the management roles, and the all of the duties of the editorial-in-chief. And I was wondering, how did you cope with the deluge of incoming papers in a time when everything is so, primordial, if you'd like, in the terms of the level of research, and in the same time, you have to try to control and prevent issues of both bad science and deliberate fraud, and we know these things happen. So do you have any new methodologies you've developed during this time to try to cope with this great strain?
I wish I had. I think the editorial process and the essence of the editorial process has not changed with the pandemic. Of course, we have developed, a faster approach to it in partnership with the scientific community and our reviewers who have been being fairly available to us to review papers much faster than they normally would do, with the understanding that it is of utmost importance for the entire world that data and vetted information is out there. I would say, I don't think we have been taking corners or cuts in the process. The process is the same, but it has been optimized to eliminate any gaps or time sinks so that we can get information out to our readers and to the scientific community as quickly as possible. So I think we all are doing the best we can within the circumstances we are all in at the moment. The pandemic has caused disruption at every single level. In editorial and publishing, that's no different. Our editors are also overloaded with work, and our colleagues also have their personal lives disrupted. So I think everyone is trying to do the best that they can within the circumstances. And in any evolving situation, there is always the potential to make mistakes. And as long as we can correct those mistakes, I think that is part of the process.
Thank you so much, Joao. That was very insightful, and I think it left us with some thoughts. And then someone who went through the process of the publishing cycle and knows both sides of that, I think that the work being done under such strain is only admirable. So I want to thank you and your staff and your team for the wonderful work that you've been doing day and night and weekends during this time to allow us to get the best science in real time. So thank you, and looking forward to the future and to some new insights coming in.
Thanks, Ron. My pleasure.
Thank you. And I think this is a great segue to move from publishing the best science to actually making the best science available and putting it into practice, making it into drugs, into vaccines, into the solutions that will be distributed to millions and billions of people. So we are very fortunate, I think, to have with us one of the key people in this industry. And I'd like to move to you, Nimrod, to take it on to the next discussion.
Indeed. What a great point of time to talk about innovation in drug manufacturing, in digital health. And it's a pleasure to have with us Leif Johansson, who is the non-executive chairman of the board of AstraZeneca. It's a pleasure, Mr. Johansson, that we take the time to talk with us. We would love to hear your perspective of the current medical innovation at the time of pandemic.
In this globalized area, it has become commonplace to talk up the latest headline, 24-hour news story, or social media storm as of global significance. Almost every day we are told events will change our way of living, alter how we look at society, and reshape how we conduct our business. More often than not, this is short-lived, as our ever-changing priorities rapidly shift our attention from one event to the next. COVID-19 is different. This terrible pandemic is a truly global emergency with over 12 million confirmed cases. It's a global shock which has deeply impacted millions of people, shaken our perceptions of how we are equipped to deal with global health crisis, and which will and should have profound implications for the future. It is vital that we learn from this crisis, and that's what I want to talk about today. I would like to focus on three themes. Firstly, the vital role of business in dealing with global crisis. Secondly, the importance of innovation and sustainability. And thirdly, that we need to build back stronger, which means capitalizing on the transformative potential of digital health. Firstly, the role of business. The responsibility corporations have to society has always been there, but it has become far clearer through COVID-19. As a global science-led biopharmaceutical company headquartered in the UK, AstraZeneca is proud to have played a key role. Our response has included emergency relief, including our donations of 9 million masks in partnership with the World Economic Forum, COVID Action Platform, and the WHO. We have worked with diagnostics, including the new testing facility in Cambridge in partnership with GSK and the University of Cambridge. We have worked on treatment for COVID-19 virus. It's important to understand that we are at the very earliest stages here, and medicines need to be approved before they can be widely used. But we are seeing some promise with 2 of our medicines. One medicine we hope will help patients not need ventilation by moderating the immune response in the lungs. That would help take pressure off strained ICU resources. And then, of course, we have worked with our vaccine program. Through our collaboration with Oxford University, we have made a joint commitment to broad and equitable access. Our ambition is to deliver a vaccine to stem the COVID-19 pandemic. This is part of our commitment to meet an urgent global public health need and support healthcare systems and economies to recover. Through our partnerships, we have now secured global supply capacity to exceed 2 billion doses and are continuing to build a number of supply chains in parallel across the world in order to meet our commitment to support global access to the vaccine at no profit during the pandemic. We expect an initial amount of doses to be delivered by the end of this year, with the remaining by the end of the second half of 2021. This response is all part of our commitment to meet an urgent global public health need and support healthcare systems and economies to recover. We are proud of the role we are playing, and that takes me to my second point, that COVID-19 has shown again the importance of innovation and sustainability to drive long-term change. By putting values at the heart of our purpose, companies including AstraZeneca can deliver benefits for society and the planet as well as for our shareholders. Looking beyond COVID-19, such a contribution can be made through fierce innovation. In life sciences, scientific innovation can accelerate new modalities and therapeutics with the potential to address the most significant diseases and areas of patient unmet need across the world. And then, of course, through environmental protection and a commitment to address climate change. Corporations have a responsibility and opportunity to be a powerful and progressive force. For example, AstraZeneca has pledged to be carbon zero by 2025 and carbon negative across our value chain by 2030. All key actors must come together to drive an environmentally sustainable economic model to deliver global health. This means taking integrated action to protect and support people and the planet, including by working with local communities. Building back stronger through COVID will require us to learn the difficult lessons of this pandemic and seize the opportunity for the future. That takes me to my third and final point, the opportunity of digital in the new normal. The digital revolution presents an enormous opportunity to transform our lives, improve patient health outcomes, save costs, and improve healthcare system inefficiencies. By embracing the full potential of technology, data, and artificial intelligence in the right way, we have a huge potential to change how we live and thrive. Data is already transforming and accelerating the way we discover and develop new medicines and will change the face of how healthcare is delivered everywhere around the world.
Thank you very much, Mr. Johansson. With your permission, to follow up on this inspiring speech, we have several follow-up questions. First of all, you mentioned, and certainly it's a promise for the world, that by the end of this year we can expect a vaccine. But we wonder a little bit about the dynamic. We know the long regulatory process it takes to develop a drug. How do you see the regulators becoming more flexible or more, I think, tolerant to accelerating development processes at this time?
I actually don't think that regulators should be or will be more tolerating when it comes to safety or side effects. The real big difference between most time assessments on vaccine is that we have such a prevalence of disease in many, many countries. And that means that we can do very large scale clinical testing before too long a time, and therefore you can say we can do it quicker. So I think that's really the most important difference compared to other time spans.
And Mr. Johansson, assuming that so many drug companies are at the same time racing to find a vaccine, do you see here a dynamic which is different than the normal dynamic in pharmaceutical, where we wouldn't have the winner takes it all effect, but rather many companies sharing the market for foreseeable time?
Yeah, I think this is probably a situation where you can see the pharmaceutical industry in general, AstraZeneca included, doing what we should be doing in a time of crisis. We are frankly just trying to help out. We do this right now during the course of the pandemic at cost for AstraZeneca. And I think this is a little like I said in the beginning of my speech, this is the role of responsible corporations to help out in a crisis. Obviously, over time, we will then have to develop a business. But I think in times of crisis, everything in society, corporations, government, academia, have to come together to try to help out.
In Israel, we organize our data, so we have actually a national data set, both synthesized data, but also a large collection of data set available for pharmaceutical companies or digital health innovation. How do you see the role of these data repositories play in the current innovation landscape? Because I know that you chose Israel for your innovation. How important is the data set in this innovation landscape?
Well, you know, Israel is very close to Sweden, my home country, in the sense that we have very good data, individual data, and data with very high integrity. And obviously, that can be used for a number of purposes. It can be used actually to find the right molecules, which is to develop medicines, you can say, versus, for example, a genetic data bank that we could have. So already in R&D, it would be very good data to have. Then when we come into clinical trials, it's obvious that it's quite a resource to be able to use for testing drugs and molecules. But perhaps even more important, as I see the healthcare sector developing, we can actually give better patient care, more individualized, personalized care to patients if we can use data in an efficient way. And then over time, that spreads actually into a much more innovative healthcare systems. I gave a few examples of that, where we can use data in such a way that we can give better quality care for patients, while at the same time reducing the total system cost for a country in delivering good healthcare. So I think I'm aware of the debate in Israel, like in many other countries, that we should not in any way misuse data or not have people trust the way the system, pharmaceutical companies inclusive, use data. But I think if we can take one step off that position and say, let's look at what we can do with data in a positive and constructive way, then I think we have much more innovation to be able to do.
Well, that's inspiring. Thank you very much, Mr. Johansson, both for your inspiring speech and really comforting and promising words for the landscape of innovation. Thank you very much.
Thank you very much. Good to be with you.
Pleasure. Ran, I guess it's the time to understand what a regulator takes in all of this.
Yeah, so, you know, these have been major challenges that were presented to us, immense, monumental challenges to try to bring a drug, a vaccine, to the public in near real time, in the millions and billions. And in order to do that, you need to be flexible as a company. But could you expect any flexibility from the regulators as well? Yeah, it's so. I think the right person to answer that question would probably be our next speaker. And it's a pleasure and a privilege to have with us Amy Abernathy, the Principal Deputy Commissioner of the U.S. Food and Drug Administration. So thank you so much, Amy, for taking the time and spending it with us today. So in accelerating science, regulation is a key tool to control and facilitate technological innovation into practice in healthcare. So has the FDA adapted in any way during this global crisis to allow accelerated paths for innovative approaches, drugs, vaccines, to fit the urgent global needs?
I think that there are several areas of change. So first is that we have put in place a number of types of regulatory flexibility. I think of this as regulatory agility, and the need is to be able to move medical products through as quickly as possible, provided that we have some confidence around safety and efficacy, effectiveness, or what we would expect in terms of the performance of the product. And to do so by, for example, putting new guidances in place that are relevant to the current COVID-19 context. So they're essentially pandemic-specific guidances that say, here's how we're going to operate. Sometimes we do this by stating enforcement discretion. So we recognize that under normal circumstances, we would enforce a certain scenario, but right now we're going to remain quiet. And also by stimulating the development of new products that are needed within the context of the market. So for example, that changes in ventilators to make sure we have enough ventilators in the market. Now, importantly, there's a second part of the innovation that goes along with regulatory agility. And that is that if we're going to have more regulatory flexibility to promote innovation, we also need a mechanism to cross-check, right? To back up and say, how are things going with our current regulatory paradigm within the context of COVID-19? And do we need to either speed up or pull back? And a good example of that is what happened with serology tests in the United States, where we approved a number of diagnostic tests through emergency use authorizations, and then ultimately needed to pull back on many of those tests on the market because they're not performing as expected. So that's a kind of an example of the second way that we do this. The third is, you may be curious about technology. This is sort of a future medicine focused conversation, and we are using data and technology in a number of ways to spur innovation and do our work better within the context of COVID-19. So for example, we're thinking about the use of real-world data, not just to understand the performance of medical products, but also real-world data to help us understand what's the natural history of COVID-19 so that we know how is the pandemic changing and how do we need to push forward the development of new medical products. We're thinking about real-world data to help us understand, for example, medical product supply chains and potential areas of drug or PPE shortages. So we're using data in totally new ways to solve for the pandemic, and it's teaching us about what we can do for the future. Similarly, we're using new data visualization techniques in that kind of way. We're thinking about the role of AI, et cetera. So there's lots of ways that we're trying to bring data and technology to the innovation space to support the pandemic as well.
So what are the plans for the immediate future, and which of these pathways will remain in place after the crisis is over and help us to continue accelerating science?
So I think that the most important part is we're going to maintain that framework of thinking about where we can have regulatory agility and also cross-checking. So that includes in the diagnostic space, the rest of the medical device space for us, as well as in therapeutics and the development of vaccines. And so the first is we recognize that in order to fight the pandemic, we need to push hard in all of those directions. And so we will continue to both focus on appropriate regulatory flexibility as well as right-sizing it as we go along and we learn. You also asked another important question, or at least I think was embedded in what you asked, which is how is what we're learning also going to sort of speak to the future? And, we have a commitment to learning from what's happening right now. And let me give you an example within the context of clinical trials. I think around the world, what we've seen is many of the ongoing clinical trials for non-COVID therapeutics, for example, come to a halt. And that is not good because we still need the appropriate development of medical products to fight the diseases we were fighting before COVID-19, right? And so we've been thinking hard about what can we do to continue to stimulate the ongoing activity of clinical trials. What were prior guidances and actions we had already taken that we want to bring to the forefront? And then also what are new actions that we want to put into place in the context of the pandemic in order to support clinical trials right now, but also learn from what's happening about how do we also conduct clinical trials in the future. And so some examples of that are that we had prior guidances that spoke to, for example, the use of remote monitoring via telemedicine and wanting to be able to understand how to do that. Now that's becoming real in COVID-19. And what we will do now is also stop to understand how does remote monitoring and telemedicine play into the integrity of clinical trial data and what might that look like for us in the future. Similarly, we've put in regulatory flexibility around the availability of investigational product, for example, the study drug, and the ability for patients to get it from their local doctor as opposed to having to travel across the country to get study drug. And then as the pandemic unfolds and we get past the pandemic, we will stop and study that and understand what does that do in terms of safety. How can we understand that kind of regulatory flexibility and its role in the future? And so we're using the innovations that need to be put in place right now to tell us what does the innovation need to look like in the future.
I see. I wonder if you had to guesstimate what would be the likely horizon in terms of an effective vaccine becoming available in the US in specific and any other country, what would be a, I would say a fair assessment of what the time horizon we could expect?
So I don't think I can give you an accurate time horizon. I don't have a crystal ball, and I suspect probably you don't either. But practically speaking, I can say that we're all working as quickly as possible. You've probably heard about Operation Warp Speed in the United States, which is really a all of government full force effort to try and develop vaccine and also other medical products, and to make sure that we're not only developing the vaccines, but planning for their manufacturing and distribution now, because historically these things have happened one after the other, which means that the timeline is dependent not only on the development of the vaccine, but the manufacturing process and the distribution process, and how can we already plan and speed that up along the way. The other thing is we're planning on making sure that as a vaccine becomes available, we're already thinking about what kinds of additional data will we need, additional safety monitoring, et cetera, across time. When will all this come to fruition? I don't really know. I don't know, is that a 2020, end of 2020 timeline? Is it a 2021 timeline? I personally ultimately want to make sure that what we're doing is keep pushing hard and fast, but we also keep our eyes on safety and effectiveness.
Maybe one last question. There's a whole lot of use of AI these days for various purposes. One of the fields people continuously in these discussions that we have to this conference have mentioned as an important or potential revolutionary step is drug repurposing and drug redesign using AI and various sources of data that would allow us to get something for COVID-19. Do you share that sentiment that there's a good chance that this approach might lead to more rapid, more meaningful innovation in practice?
So I certainly am hopeful. And it goes to my area where I think we've already seen some aspects of drug repurposing play into a positive story. The dexamethasone story is a really great example of drug repurposing in the context of COVID-19. How does AI come into this? And I see a number of ways. One is it helps us sort through all the many potential available drugs for repurposing and ask the question, where might there be a good match that then can be pushed through in more traditional development methods. Another place that AI has a role that's going to help, I think, to speed this up is to help us really get data sets cleaned up and better ready to be able to be used to understand how these drugs are performing. And so I see a role for AI there. I also see a role for AI to help us get smarter about conducting operational tasks and essentially performing a role within the context of robotic automation and other artificial intelligence-based activities. And, you know, do I wish there would have been a sort of a eureka aha and many different AI solutions would have come to bear? I think we all do. Do I think we're sitting on the precipice of many different ways that data technology and advanced analytics, including artificial intelligence, are really going to push us into the future? Absolutely. And so really one of the core tasks is to figure it out now and then figure out what that's going to tell us about our future.
Thank you so much, Amy. And I think that what you've just said, I want to get another viewpoint on this, and we're fortunate to have with us Professor Zach Kohani. So, Zach, I want to jump back to this same issue that's bothering me. We had so much expectations from AI, years of building international hype, and a lot of actual practice in many domains and also in healthcare. So we thought, you know, this is the technology that will come to the rescue and will save us all from the COVID-19 event. But, you know, almost nothing. How, as someone who's been doing this throughout your life and teaching so many students, what's your take on this? How come so little was achieved?
The result in terms of the application of AI to our threat was underwhelming. In fact, it was possibly not only silent, but in fact, it could be argued it was anti-constructive. And I say that because there is a view of AI and machine learning, which says you learn from the data and you come up with predictive models. And I've argued this in the JAMA piece, that there's actually a continuum between these fancy recurrent neural networks or convolutional neural networks and logistic regression. These are just part of the machine learning tools. And so if you look at all the models that were created to predict how many cases, how many deaths there were going to be due to COVID, they were systematically wrong throughout. And worse, leading practitioners throughout the world were throwing mud at each other for the performance of their models. So it was very, very unimpressive performance. And there were several attempts to use aggregate data from electronic health records. For example, in the United States, the company Epic has a predict system to predict the severity of disease based on the admissions, and it didn't perform very well at all. And I think the answer is we in healthcare were shooting for the moon, but we actually had not gotten out of our own backyard. And what I mean by that is our data, the quality of our data, and the quality of timely data was very, very low. And most of the data that was being shared for the first 3 months was literally just case counts and death counts. To the extent that there was sharing of clinical course, it was from single institutions. If you don't control the quality of your data, if you don't understand how the sausage is made, as we say in the United States, you don't, anything beyond that is frankly somewhere between a waste of time and misleading. And so I think that's the real problem. We didn't have high quality data that we understood across healthcare systems. Individual hospitals could do that, but across hospitals it was not working, and therefore we actually did not have a real collective intelligence. And it's a sad thing. I think if we had had artificial intelligence coupled to really high quality data, doctors could have been given that authoritativeness much faster than the old slow motion way we have of accumulating experience across hospitals through the conversation network, through the rumor network, through the slow publications. That would have been incredibly helpful and many lives would have been saved if we had that virtuous cycle of fast, high quality data with machine learning, looking for good hints about what's working, what's not.
So with all of this, are there any real success stories around the globe regarding AI that you can share with us today?
For me, the most compelling example, and potentially one that will have huge public health impact, is the development of vaccines based on predicting which protein moiety is the best targeted, either on the human receptor side for creating blocking antibodies, or on the viral side. And for that, they use large databases of protein interactions and of docking simulations to figure out what might be the best protein to block and a protein domain to block. And several of the vaccines that are now entering in July in phase 2 testing were developed on these machine learned predictions of which target to actually look at. And in the case of companies like Moderna, it's purely went from in silico to, okay, let's target by synthesizing the messenger RNA for that protein to create the particular vaccine. So we will see in December the results of phase 3 trials, or maybe even sooner, phase 3 trials from purely machine learned targets.
Thank you, Zach, for this inspiring talk. And I think this is a good segue to discuss the same topic with a science that does AI on his everyday job. So, Nimrod?
Yeah, indeed. We have local scientists who are doing marvelous work in this field. So it's a pleasure to speak now with Professor Eran Segal, who is from the Computer Science Department at the Weizmann Institute of Science.
So one of the main challenges that we faced is to stay one step ahead of the spread of the virus, because as we know, if we begin to act only after there's confirmed cases, like what happened in Israel, then it already may be too late, and we may lose control of the epidemic because of the cycles of infection that have already occurred. So what we'd like to do ideally is to come up with a solution that would allow us to detect regions of spread of the virus ahead of time so that we could flatten the curve even further. And we at the Weizmann Institute asked whether we can use population-wide 1-minute surveys in order to predict ahead of time regions of outbreak. So we set up a very simple chatbot that every person can answer in about a minute, that asks about symptoms that we know are associated with coronavirus infection. And then what this system allows us to do is to obtain a real-time map of high-risk outbreak regions at the entire level of the country, at the city and neighborhood levels. It allows us to predict regions of spreading of the virus ahead of time. It allows us to evaluate the effectiveness of various measures, lockdown measures that we take. And it also allows us to come up and gain more insight into symptoms that people develop and better prioritize individuals for testing. We started this very early on in the pandemic. Right when we started this, I believe we were the first in the world to start with these surveys. Several countries contacted us and wanted to replicate what we have done. So we formed together a consortium that we have led together now with 11 different countries. And this survey is now being deployed in all of these countries for exactly the same goals. We published a paper at a high-impact scientific journal, and we are forming a coalition of all these countries to share insights and data and methods of working on this, as has been done in other areas. And so I want to share with you a few of the insights that we obtained from this. So the first one was when we looked at the accumulative symptoms that we have in various cities here in Israel, we saw that the symptoms survey, which is shown here on the y-axis for various cities, versus on the x-axis, the number of newly confirmed cases that will occur 1 week after we look at the surveys, we saw a high correlation between regions where we knew symptoms are occurring in individuals and regions where newly confirmed patients will be identified in a week from now. And the reason is very simple. If you start to feel symptoms, then it'll take you a day or two until you decide to go to do a test. And then the test itself takes a few days to obtain a result until you get it and so on. So by asking people with technology digitally in real time, we can already obtain this prediction of cities that will be ahead of time, regions where we'll identify newly confirmed cases. So we use this, and we shared this data with the Ministry of Health, which together with other information that it had, used it to control regions of spread of the virus. But beyond just predicting regions of outbreak, this tool also allowed us to obtain several additional insights. For example, when we take various actions, like the lockdown, very heavy lockdown that we did here in Israel, this tool allows us to track what happens to symptoms of individuals. And what we found is that right after we had the lockdown in mid-March, the symptom level of symptoms in individuals was relatively high, and then we saw a very sharp decline that occurred over the course of about a week to 7 days that allowed us to evaluate as another measure the effectiveness of the various lockdown operations that we have taken. And now that Israel is having a second wave, we can further evaluate the various actions, various limitations and restrictions that we put on the population in terms of how they affect various symptoms that people are feeling. And the final insight I want to share is that once you ask many people how they feel and what symptoms they develop, you can actually identify new symptoms that were not known before when you only ask, for example, hospitalized patients. And so early on, there were some reports that loss of taste and smell may be a symptom of the disease. So we added that to the survey. And indeed, what we saw over the course of collecting these surveys from 3 million people here in Israel is that actually loss of taste and smell was the single most distinguishable feature between those who have been infected with the virus and those who have not. So there's about a 35 times more chance that if you feel loss of taste and smell, then it is due to coronavirus infection as opposed to something else. For example, fever is something that is much more common to various other diseases, and so just having fever is less distinctive as compared to loss of taste and smell. And indeed, insights from this survey, both in Israel and the UK and other countries, have led to incorporating this symptom into the criteria for actually being tested. And furthermore, we were able to take all of these insights together and develop an algorithm that could better predict the result of a PCR test for coronavirus infection. And so now, digitally, online, people can fill out their symptoms, and the algorithm can predict for them and prioritize better who we should test for COVID-19 infection. And by that, we could more readily identify individuals who have been infected and better control the disease.
Thank you, Eran. I understand, Ran, that with your work at Clalit, you've been doing a collaboration on symptom checking, utilizing the same AI modeling in your collaboration.
Indeed, we have a long-standing collaboration with the Weizmann Institute at Clalit, and specifically with Eran's team. We've had quite a few studies that we've done together, and looking forward to the next one. So thank you, Eran, for your time. And now we're in for a real treat. We've had a very interesting discussion with Karen DeSalvo, who is the Chief Health Officer for Google Health. And let's hear what we've been discussing.
Karen, thank you so much for taking the time. It's a pleasure to be with you today. And I think that it is non-trivial that you could spare the time.
Oh, I'm delighted to be here with you. It's really good to see you again. And I'm glad to see that you're faring well in these awful times.
It is very challenging times for everyone, which is really, I think, the point in time where the world is desperately seeking new ways to confront this, old new challenge of a raging pandemic, right? And what I would like to ask first, that in your unique experience and viewpoint, both in your current and your past roles, what innovative solutions could we expect that will potentially transform the way we tackle COVID-19?
My background is not only in medicine, but in public health, Ron, and being at Google in this historic time has been meaningful for me. I know, having been through prior crises, public health crises, getting information to the public is one of your biggest challenges in any of these kind of events, especially authoritative, accurate information and directing people to what they need to do. Billions of people come to Google every day asking for information, and COVID has not been an exception. So a big priority for us here has been to make sure that we're getting good, accurate information to people all over the globe about COVID-19, about the disease itself, about how it's transmitted, about where to go for help and assistance, pointing people to their local ministries of health, to the World Health Organization or the CDC. So this has been a priority not only on the search surface, but also we've been able to lift up content on places like YouTube and invite folks like Tony Fauci to be interviewed by influencers that will reach broad audiences and make it more engaging and entertaining, so that people feel more empowered and have the agency to know what to do for themselves. So very pleased that we can be part of this sort of new way of communicating directly with the public in a pandemic. Hopefully this will be the last pandemic where we need to leverage these kind of resources. Though I have to say, I mean, the scale of what we're able to do when we put out a new message, whether it's about COVID or something related like mental health, we can reach so many people overnight, and it's been a great thing that we've been able to do. I think it's part of the bigger fabric of everybody's role in fighting the pandemic.
Cool. So how's Google Health actually involved in making these potential avenues of innovation in practice materialize? What is the time horizon for some of these new ideas that you are planning to actually be unveiled?
So in context, I've been at the company now just about 8 months, and Google Health, which is what the part of the company I joined, was about a year old when I arrived. And our focus was on improving access to health information for users and for the people they trust. So how can we get health information organized in the way that search organizes information for the rest of the world on top of the electronic health record, or leverage artificial intelligence or computer vision to accelerate diagnostics and imaging work that happens in the clinical environment. But also, how do we give consumers the information they need to take action around their health, whether it's learning about diabetes and getting care in those, finding sources of care in that environment. I tell you that the sort of context with which I walked in the door here and what Google Health was thinking about, the pandemic accelerated a lot of that work for us. It was an accelerant use case, is the way I think about it. And so though initially our clinical team that we were building out was going to be focused on those two broad areas, the public health part of our work really exploded. And we have been working then across the company in partnership with Search and Map and YouTube, some of the parts that I mentioned, but it goes well beyond that, to consider an enterprise-wide approach to improving health and health information for people all around the world. So the work that we wanted to do inside of Google Health, we still do. We still believe and are still working on this idea that when the pandemic passes, that the same challenges we've always faced, that you need good information to make good decisions, whether you're the doctor or the patient. And we want to help people navigate their health journey just as much as their care journey. So we were going to continue all that work, but I'll give you a concrete example of how it accelerated, and that is in the area of telehealth. The company has done some work in telehealth broadly, including with cloud. One of the things that we worked on in Google Health was getting information to consumers about how to get virtual care options in their area. So rather than, if they were sick or if they had chronic disease needs, rather than having to worry about going in person, especially at the height of the pandemic, they would be able to find resources to have virtual care. And we not only made that a part of the search function, so when you're looking for care, it pops up the options, but we use that as an opportunity around price transparency to put up the pricing of the various options to start to give consumers a sense of how to make choices based on not just quality, but also trade-offs and the overall value. We had planned to do some of that work, but clearly the interest in telehealth and the need for virtual care in COVID accelerated our work in that area, and we'll continue that pathway. It's just an example of how the pandemic became an accelerant use case for the kinds of things that we wanted to do in Google Health.
Cool. So I think that's a really cool example. And actually, that's the exception that really begs the question about the rule. I myself had huge expectations about how AI, once there's a big global challenge, AI will rise to the challenge and change everything. But when we look at the practice, as compared to those expectations, we've seen such few tools implemented to date in terms of AI in practice in COVID-19. So why do you think this is the case? And can we change that in any way?
I think it's probably okay that we don't rush too much for two big reasons. One is the data in is still not all that clean. You guys are well ahead and haven't harmonized really great data that's interoperable. So kudos there, but the rest of the world not quite in that place. So yeah, there's a need to make sure that we have non-proprietary harmonized standards that can make it a more seamless input. And then I think there's a really important challenge for those who are using AI to look at fairness and make certain that whatever we are building is not going to exacerbate inequities in care or health outcomes and really eliminate disparities. I think that's one of the most exciting potentials, frankly, for AI and the augmentation that it can bring to bear.
I wonder, because of those roles that you've taken in the past on the federal level and in decision makers level, I'd like to take the opportunity and ask you at this point, what pieces of advice would you give country leaders as they need to make such tough decisions now in short time and very little evidence around them to guide them? So you know, as a decision maker and as a leader, and what potential advice can you give at this time?
I think the reality is that the scale and scope of building consensus recommendations really falls to governmental entities to try to bring the smartest people and the best science together. And we're hungry for it in the private sector. We want to inform it, we want to partner, we want to know how we can augment what's happening. But I think that role is really essential. And I don't think I understood that quite as well until I was on the other side. Working to make sure that we were making good decisions for our Googlers and how to keep them safe around the world and their families, and be a part of the necessary efforts to reduce contagion. I mean, I think an example of how we partnered with government is in public health. I think I mentioned the community mobility reports a minute ago, that a lot of my public health colleagues and people in public health around the world were trying to understand the reaction to the social distancing, the shelter-in-place orders. And they would tell me stories that did not seem surprising to me. Having been in public health, that they would look out the window of their office to try to sort out whether people were still driving or walking, and if they were staying home, which is a really inefficient, non-evidence-based way for them to make decisions. And so that led us to develop this community mobility reports, which is a way to aggregate data in a way that we do for restaurant busyness, and look at busyness in other sectors to inform them about whether they needed to press harder on the public health expectations or lighten up. But we wouldn't want to make those rules, and we wouldn't want to, we as a company, we just want to inform the process and partner with public health to augment any data that they might need to have. So I guess that's the second thing, Ron, which is partnership. And frankly, I think the world's been doing, honestly, a really good job of collaboration and partnership. But I want people to know that public-private partnership is essential when you have the scale and scope of a problem like we have. But I also think that going forward, which I've always believed, that this is a collective action kind of thing. Everybody's in, everybody's got a responsibility, and you bring the best tools to the table. As you know, from Louisiana, and that's our gumbo approach: bring the best that you got, put it in the pot, and you come out with something really wonderful. And I think we're seeing that in action in COVID, but I do want folks to know that everybody's got a role to play.
That's really, I think, one of the key themes of this conference that repeats again and again is the need for collaboration between countries, within countries, between sectors, between the private sector and the public sector, actually between the security sector and other sectors. It's all about collaboration at this time of need. So thank you for making another note of this at this point. The last question that I would like kind of to inquire, and I know it's sometimes difficult at the middle stream of this is far from being done, but I would like to still ask you, looking back the last 6 months, what has Google Health in specific done in this time period? One thing that you were most proud of, and one thing that you think you would have done differently if you'd given a chance to redo it again?
Well, I have to say I'm really proud of what we've done, and I'll start from the beginning, which is thematically around getting information to consumers. Back in January, we realized that we were moving towards a pandemic, and leveraged a tool that we have on search, which is SOS, which is an alert that can drive people to urgent information. We've used them for things like the tsunami, but we've never used one for a communicable disease outbreak, and it seemed clear that we needed to lift up really important authoritative information quickly. So we very early stepped into wanting to make sure that we had good information out for the public, and scramble, I don't know what's the right word, but that watching, being relatively new to the company and watching these engineers and product managers and UX folks who didn't really even understand viral disease transmission quickly learn what it meant and how to translate that into information that our users could access was remarkable to see. I mean, everybody just turned on a dime and tried to sort out where were all the places that people might look for information from us, what are all the surfaces, and how can we get that information out there. We did creative things that we haven't even done before, crossing, and it's a long story to try to explain, but like there are things that YouTube always only does, ways that they only do banners, and they said, you know what, the world's in an historic time, we've got to get information out to people to save lives. And so really thinking about how we leverage the surfaces, the places people can look for information. I'm really proud of that. I'm just proud of everybody who turned and said, all hands on deck, and we were still in that mode. We're thinking a lot about masks. We're thinking a lot about what's going to happen with vaccines and how we can really continue that messaging. I'll say the second thing, which is about the company, and we decided very early to take a conservative approach to work from home. We did that. We wanted to be not only for the Googler protection, but to be a part of this social distancing dedensification work. And so very early we wanted to, because we can work from home, and we're taking a continued conservative approach there just to be a part of the bigger solution.
Thank you so much, Karen, for this time.
Thank you so much, Ron. It's great to see you. Stay safe. Everybody wash your hands, wear a mask, keep your distance.
Nimrod, I think this concludes our third and basically the last part of this part of the conference. And what a ride this was, wasn't it? I think this exceeded any expectations that I have had. I mean, I've learned so much from what I've heard today.
I think it was a fascinating ride. I think we've learned about the importance of data, importance of innovation at the time of this crisis. We understood that decision-making processes should be supported by data sets. The tools are available and technology is available already to predict and to help to plan the decision-making, both at the country level, but also on the individual level. We understood how startups and innovation are changing and pivoting their innovation to meet the challenges of COVID-19. And most important, I think we learned that we can accelerate the processes to bring a better healthcare solutions and a better health system now with the technologies that are capable to handle these challenges.
Yeah, I think we enriched our tool set to cope with the challenges that we are experiencing now, but also those that are coming in the future. And we will be utilizing the tools of better decision-making processes, of technology, and of accelerated science, and do all of that while tackling the challenges, the risks, the perils, with all of the recommendations and lessons learned that we've heard from these amazing set of luminaries that have taken their time. Some of these people really do not have the time to stop and take interviews, and they did pause for just 1 second this day in order to share their ideas, their concepts, their aspirations, and their lessons learned with us. And we thank you all so much for that. And I think we've been blessed to be able to do this. And this is a great point to conclude this part of the conference. Right, Nimrod?
Thank you very much, Ran, and thank you for chairing this conference, and thank you for the opportunity to host this exciting day together. Stay tuned. We are continuing to the fourth part of the day, which will be the bioconvergence session that we'll have with partners of this conference to discuss how bioconvergence is helping us to cope with current needs. And now to our bioconvergence session. Bioconvergence is an innovative approach. It integrates biology with engineering, AI, physics, computation, nanotechnology, material science, and even advanced genetic engineering, all to address the unmet needs in health and other industries. In this session, we're going to talk with experts and innovators and companies that took solutions from other fields like engineering, physics, robotics, and address the unmet needs of the health industry. We're going to talk with them about how innovation in bioconvergence help to cope with COVID-19 challenges.
Thank you, Nimrod. I do agree. I think that the concept of bioconvergence has been with us for a while, but never, I think, in recent history was there a time where the need for bioconvergence was so immediate. And so I'm very happy that we have with us our partners and sponsors taking part in this unique session in order to give us a more in-depth view of what bioconvergence in these days really looks like and what is the potential of it to help us get faster into a better, I think, healthier future, thanks to the combination of all of these domains of science and knowledge into one singular point in time. So looking forward to this wonderful session.
Thank you, Ran. And now I have the pleasure to speak with Dr. Irit Idan, who is the EVP for Research and Development at Rafael Advanced Defense Systems. We're at a conference about FutureMed. Rafael is an advanced defense system company. I assume that many of our audience do not know Rafael in this context. Could you a little bit tell us about Rafael?
Yeah, I will. I'll be happy to do that. Thank you, Nimrod. Well, Rafael is the third largest defense company in Israel. We have a worldwide reputation for our cutting-edge solution for the defense market. Our products such as Iron Dome or Trophy are used by Israeli Defense Forces, the US Army, and the British Army as well. Rafael was established 72 years ago up north, in the north part of Israel. We have over 8,000 employees working on different parts of the engineering and the science world. And through the years, recognizing our extraordinary achievement, we received over 52 Israeli Defense Awards. I know a number that cannot be matched by any other company in the country.
You know, as Israelis, we admire Rafael for what you've done for defense. But I think very few of us would think of Rafael in the context of medicine. How Rafael is connected to medicine?
Well, the world of medicine is no different to Rafael. I'm holding here in my hand Pilcam. I guess some of the people in the audience know it. Well, actually, this is a pill that you swallow, and it's a miniature camera that takes pictures while going through our digestive system. Well, this is actually a spin-off of one of Rafael's core technologies, an electro-optic missile seeker. So what you have here inside is a very unique electro-optic camera that takes the picture while we're here. So this was the first, if not, I think, the very first successful leg that Rafael had in the medicine. Afterwards, we have Medinga, which was an insulin pump, and other products as well in the medicine world as well.
That's fascinating, and certainly as we discuss bioconvergence and how you take domains of robotics, engineering, AI, and adapt them into biology to bring solutions, that's a fascinating example. But I want to take you to the human side of it. COVID-19, sometime in February 2020, we understand that COVID-19 is going to change our world and that there is a new challenge we are facing. I guess there is a management meeting or a board of directors meeting at Rafael, and you understand that the world of yesterday is not the world of today anymore, and the challenge is no longer defense. It's a new challenge. What's happening in such a meeting at Rafael?
Well, I'm not sure it's just in Rafael. I think it's all over Israel. The DNA of the Jewish people, of the Israeli people, is always, in time of trouble, coming together. It's always to get the best of us. So the same thing happened in Rafael and in other companies in Israel. we were sitting, and suddenly I'm getting hundreds and hundreds of ideas that coming from our employees wanted to work and help the country in facing this pandemic crisis. So from the beginning, I set only 2 rules. Okay, A, it has really answered a problem that the medical staff in the hospital had, and B, we have to finish the development of that product within 3 to 4 weeks so it can be implemented in the hospital as well.
So it's like a real-life hackathon.
It's a real-life hackathon working together with the hospital. So I remember at the beginning, me and my team, we were traveling in hospital. We went in a coronavirus ward. We talked to the doctor, we talked to the nurses, we talked to all the medical staff, try to figure out what are the real problems that they're facing. I remember one Saturday, I was in a Zoom with one of the doctors in the Rambam hospital, and she put us in her pocket. She went into the corona wing, and for 90 minutes, I was watching what she was doing, what are the problems that she is facing, and trying to figure out how can we help her using our technologies that are coming from the defense world.
So I understand the process is the following. You first sort for the problems.
True.
You need to understand with the hospitals or with the ones who are facing the problems, what kind of problems they're facing. And then you need to go home and see how your technology can be adapted for such problems to provide a solution which, as you stated, has to be immediate and applied to the field without any regulatory process.
True, it was like that.
So,
but it was much faster because while we were traveling with her in her pocket, we already got the idea of what we needed. So the first thing was we need to limit the amount of times that the medical staff has to go into the corona wing. For example, they have to get dressed, they have to undress themselves. It's a complicated procedure that really exposed the medical staff. And we try to figure out ways of how to help them by understanding what kind of task they have. For example, they're going into the ward to give food and medicine. So we took a Temi robot that were used in Israel, and we just add to that using our core technology in computer vision, in communications, and in other stuff. Add to that with the robots. So now the robot could go in the hospital. It can deliver the food. It can deliver the medicine. The medical staff remain behind. The robot itself can navigate itself autonomously through the beds. One of those robots is now, a few of them, actually, not one, 4 of them are now working in Hadassah, in Jerusalem, in Shaarei Tzedek. And what they ask us to do is to do the communication between the people that outside the family and the ones that are ill. There are research saying that even those that are under sedation and things like that, it's very important for them to hear their loved one voice. So we created this kind of the communication between them using this robot.
That's fascinating. You're taking core technology in robotics. You don't need to do any adaptation which would require a medical device certification,
True.
But you apply on top the wisdom of computer vision and the analytics on top in order to provide now a solution not in the defense field anymore, but for caregiving and communication with the ones that need.
Whatever the problem is, we told the hospital there are now around 30 kinds of robots wandering around in corona wings in hospital in Israel. Whatever the problem the medical staff has, we are sitting with them on a weekly basis and giving their solution for that.
I know that there was another challenge that was very common at the corona time. It's the problem of exposure of the medical staff. That the medical staff was exposed to air saline and the breathing of the patients. And many were looking for solutions that can help the medical staff not to get exposed and infected. I understood that, again, Rafael came with some adaptation of existing technology.
True.
Now to engineering to provide a solution. Could
That's
you
right.
share with us a little bit?
Well, the problem is that those who are under open ventilator system, they have an aerosol of the virus around their mouth like that. So what we did, we took the gas mask that we have from what was it? Was
Iraq War.
the Iraq War, the first Iraq War, and this mask was built for the one that had beer. So it's like an airtight container. And we make the adaptation to use it with the ventilator machines. So actually what we create is like a closed room around the man, around the patient, and allow him to use the ventilator, but not exposing the surrounding to that. Well, actually, some of the doctors who saw this solution immediately asked, well, it's good for them, but it's also good for us. So we had some of the doctors in the Carmel Hospital in Haifa using this for their own use to prevent their own...
That's an incredible story. I also heard another story about Rafael, which was fascinating, that you took technology that is used at the field, in the battlefield of thermal imaging,
Sure.
that used many times in order to sort targets in the field, and adapted it for the challenge of mass actually analyzing or mass sensing of the community for thermal problems. Could you share a little bit with us about this solution and how it was adapted?
Yeah, one of Rafael's subsidiary companies called Opgal is developing thermal camera, very simple one. And from the beginning, we knew that this corona pandemic is not like the SARS. Well, there is a 2 weeks long time until you get all the symptoms, and you could have people walking with having a fever. And we wanted to prevent those people from entering public places. So using our technologies in optical imaging together with Opgal thermal camera, we were able to produce a camera that you put it at the entrance to any public places and measure the heat of the people that are moving in. I remember the first day that we put it in Bnei Zion Hospital, and there was an elderly lady coming in, and we had the manager of the hospital standing with us, looking at the camera, and he immediately looked at her and says, "Excuse me, lady, you have a fever, go to the emergency room." And she says, "I don't have fever, I just came for my eye check." And he told her, "No, ma'am,
Amazing.
you have fever, go immediately to emergency room." She didn't have corona, but she did have fever. So this one is actually implemented at the gates of Rafael. So today when I want to go in to Rafael, I go through that, and that checks my temperature.
Very fascinating. We understood that another challenge that was very dominant at the pandemic time was the shortage of production. That many companies that had solutions like respiratory machines or other solutions which are and pumps which were necessary for the hospital could not just meet the production challenges. I understand that Rafael is a company that has high volume production lines and a lot of experience in production optimization. Also came up with some solutions how to reutilize machines for more than one patient, but also how to expedite production processes. Could you share with us a little bit about this perspective of...
Yeah. Well, in terms of ventilator, we did two things. We adopted a very small company in Israel that is building ventilators, FDA-approved ventilators. Usually, it used to do like 30 ventilators per month. And then she received an order from the Minister of Health in Israel, please provide us with 1,000.
Wow.
Well, it's a small company. It's very difficult for such a company. Its name is Flight Medical to really produce this enormous amount of machine. Therefore, we helped her in the production line. We didn't do that ourselves. We helped her with our production lines to do that machine. We solved their problem. For example, they have problem with the electromagnetic compatibilities. So we took the parts that they have problem with, and we brought them back to Rafael into our labs. And you can see Iron Dome missiles on one side and ventilators on the other side. And we have to solve this problem, and we did it. Within 24 hours, they had a solution that they were working on it for a couple of months. The other thing we had is while working with a doctor from Hadassah emergency room, and she told us, well, we are the doctor, we used to work with certain types of ventilator. It's very crucial that the doctor in emergency cases know the machine that he is working. So she said, I rather work with one ventilator and want that this type of ventilator will be used by more than one people. So we developed, together with her, adaptive splitter for the ventilators, where you can use it on more than one patient, and you have a control on all the parameters that this ventilator is used.
And this does not require any FDA approval or any medical device?
We use only the regular medicine component in that respect. It was not used in Israel, but like all of our development that we did through the Corona time, I send them to the world. I send them to all of Rafael agency in the world. I put them in the open, the web, and tell, well, everyone who wants it is more than welcome to use it. And 2 weeks ago, we received a letter from Chile that is suffering quite drastically now from the corona, when they want to thank us. They got the blueprints of this adaptive splitter, and they use it now in hospital. They have a really shortage of ventilator, and this is the solution that they are using. We just shipped it to India and to other places.
There's another perspective in what you're telling, is this kind of like open source approach.
It is.
Which is certainly not common for the defense industry, but here I understand you took a very different approach. You opened up all your portfolio of innovation that is relevant. As you're saying, the blueprint is in the open and saying it's here for everybody to utilize.
Yes. Well, this is a crisis. It's a world crisis. We have to find the benefits of what we can give back to the world. If you save one people, it's an amazing. I remember this doctor writing for me when she heard about it, and she said, you know, I'm saving in the emergency room every day 1 or 2 person. What you did here with this adaptive splitter is going to change the world of medicines. So you should be so proud of your people. And I'm really, really, really proud of them. They did an amazing work.
It's not only that you brought innovation to the world at a time of need, I understand it also opened up new diplomatic relations, a new actually international relationship we didn't have before. I understand that you signed an agreement with the United Emirates for the first time, an Israeli defense company, in order to co-develop or to work together on a project. Could you share with us this historic moment?
It was an amazing moment for me last week when we signed an MOU with G42, a company from the United Emirates. And it was like, for me, a dream come true. We can use together our knowledge and our technologies to work on things for the humanity. It's not for the defense, it's for the humanity. And we, and I'm guessing the other company as well, looking forward for this collaboration. It was truly an inspiring moment.
It seems Shimon Peres' vision of diplomacy through innovation and technology. Thank you very much, Irit. It was a pleasure.
Thank you.
And now to Anya Eldan, Vice President at the Startup Division of the Israeli Innovation Authority.
Bioconvergence is a transdisciplinary field that merges biology and engineering, AI, nanomaterials, and it represents the next technological wave that will change and revolutionize the health tech industry. And this is what we're going to talk about. I represent the Israel Innovation Authority. It's a government agency entrusted with supporting sustainable economic growth through innovation. We recognize bioconvergence as a strategic field for building the next economic growth engine in Israel, similar to the ICT with which Israel has been so successful. Bioconvergence will influence the entire ecosystem, and today we're going to talk to representatives of all sides of the ecosystem. In this panel, we will meet the academic researcher, we will meet a very young startup, we will meet experienced executives, we will hear the point of view of pharma companies, of medtech companies, of tech giants, everybody who is responsible for making this field so successful. And we're ready to start. Efi Cohen-Arazi. Your career includes executive positions in biotech and medtech industry. You were CEO of the first bioconvergence investment company in Israel that created such amazing scientific companies like Enospace, NanoRetina, and Blue Wind. And now you're back at the beginning with a new startup, bioconvergence startup, of course. Please share with us how this convergence of discipline is changing the health tech? And what are the special challenges in bioconvergence?
Thank you, Anya. We are indeed living an exciting time for the healthcare industry, and it does remind me the early years of biotech industry, where we did biotech work with genetic engineering, biology, microbiology, biochemistry, and process engineering. And later it grew up to become the biotech industry, which is now valued at hundreds of billions of dollars. And they actually delivered very nicely on the promise of treating unmet problems such as multiple sclerosis, cancer, rheumatoid arthritis, bringing the monoclonal antibodies and gene therapy and cell therapy to the market, creating a dramatic change in the healthcare industry. Very similarly, the bioconvergence reality is now being formed, converging different technologies from certain academic and industry space to bring the next generation of solutions to the healthcare industry. And what is the promise here? The promise to make a dramatic change in the healthcare system. Everyone knows that the healthcare budgets in every government now is unsustainable. And the promise here is to affect dramatically the spending of healthcare, on healthcare, by reducing the cost of hospitalization and treatment. Our aim with bioconvergence is to have early detection, early diagnosis, and prevention to avoid treatment and hospitalization. And when you do treat patient, it would be cheaper, more accurate, and more successful. So the promise here to make a big revolution, especially in the budgets of healthcare.
But bioconvergence is not easy. Nanoretina came up with a science fiction idea 10 years ago of returning sight to blind people. Today it has performed 2 first implantations in humans. Is it going to be easier for new bioconvergence companies?
Of course, we believe that with the convergence of technologies today, we would have started and completed Nanoretina much faster. If you look at Nanoretina as a platform, as an artificial retina solution, I can identify at least 12 different technologies that are expressed in that single implant. Today, when we started it, we had to go and search for the solutions that were, at that time, breakthrough, state-of-the-art solutions in different locations around the world. And when we are now have more availability, more accessibility to low-cost, high-powered software and technologies and chip manufacturing combined with biological solutions, that will enhance, that will simplify, that will make treatment and solution available faster and cheaper.
Very good. And another thing about bioconvergence is that it is not created by 2 young entrepreneurs in a garage. Most of the innovation comes out of years of extensive and innovative academic research. Professor Ronit Sachi-Fainaro, you had a bioconvergence lab. I'd like to call that bioconvergence lab at the Sackler School of Medicine in Tel Aviv University. Tell us what it means.
Hi. Yes, our lab is composed of 30 young scientists that come from different disciplines, from chemistry, biology, computer science, engineering, even architecture. And they all work together on different projects that have common denominators in terms of the big idea, the macro. And if we are now trying to develop a cancer vaccine, so we need first the MDs and the surgeons to give us a little chunk of their tumor. And we need then the biologists to come and sequence that tumor, the RNA, and get all the RNA and the proteomics data from those tumors and comparisons. Then we need the bioinformaticians to find which antigens are expressed in that tumor. Then we need the engineers and even the architect that will take all this information from the image, from the MRI image, do the image analysis, and use a 3D printer to print a mini-me model of those tumors that were half an hour ago in the brain, for example, of a patient. And now, after printing it, having, as you can see here, a mini brain that inside there is a melanoma brain metastasis, but we need also the blood vessels. So these blood vessels need to be functional and they need to be connected to a peristaltic pump with tubes so that we can flow in them all the blood, the immune cells, and also the different drugs that we are synthesizing in the lab. And for that, we need the chemists that will synthesize those compounds, going back to the biologists to test them on those models, and hopefully at the end, going back to the physician, to the clinical world, and going to clinical trials. So from bedside to bench and back to bedside, this is how we see all these transdisciplines network going on.
Bioconvergence indeed. And the exciting thing, I think, is that you're creating bioconverging platforms that can actually be adapted very quickly to new disciplines. And I find that very interesting. So your application is cancer. But you were able to move very quickly to use the same platform for COVID-19. Please tell us why it's possible.
Right. This is actually fascinating. Obviously, if we put on the side the devastating effects in terms of the economy and health and all the other global effects that this pandemic had, in terms of science, all these platforms that we have developed for a very long time, and if I focus on the last 5 years on this nano-vaccine for cancer, the platform is already there. It's ready. All we need to do is switching between antigens, those proteins, small sequences of proteins that are expressed by tumor cells, now go to SARS-CoV-2 and take, for example, the spike, those spikes that are in the corona of the SARS-CoV-2, select by bioinformatics tools the correct sequence and put that instead of the tumor protein. So this allows us to very quickly adapt between different projects, moving from cancer to infectious disease, because the rationale is the same. It's activating the immune system against a tumor cell or against a protein of a virus. The idea is the same. It's sharing the same.
It's quite amazing how COVID-19 made everything so much faster. We published a call for proposals for COVID-19 solutions. We received 900 proposals within 2 weeks, including such amazing breakthrough research from leading scientists and from startup companies. And Ronen, my next guest, Ronen Ivry, CEO of Barcode Diagnostics, you also demonstrated how you can switch very quickly from one application to the other, even in a startup company that's very, very young. Tell us about Barcode Diagnostics.
Yeah, so Barcode Diagnostics is a company in the field of precision medicine. We work on cancer, and we actually try to find the best solution, the best drug for each cancer patient. And we do this by using nanomedicine or nanoparticles that we send into the tumor. We encapsulate inside the nanoparticles the small drugs that go together with molecular barcodes to identify these drugs. And as a startup company, we asked ourselves, how can we help fight with the current knowledge that we have and the exceptional team that we have inside the company. And we came up with a diagnostic solution which is also science-based. So you're talking about moving forward very quickly. We're using the knowledge that we've acquired. We're reading around what's been out there in the world. And the diagnostic solution we came out for Barcode Diagnostics is a solution that's based on molecular barcoding. So taking our tags that in cancer are used to identify the different drugs, we can take them and identify the patients. So in this way, we can read and test different patients in COVID-19 and tag each individual patient and then use the barcoding technology to find out who is infected and who is not infected. And this is, I think, how bioconvergence works, is a dynamic of the team, of the company, in our case, of the academic institutions. And I think that's what's very exciting about bioconvergence.
And Barco Diagnostic also came out of a leading research institution in Israel, so we have to mention that.
It had. So Barco Diagnostics was established from the lab of Professor Avi Schroeder at the Technion. And their exceptional work was published, and we founded the company with the help of the Israel Innovation Authority, and we're continuing to grow together both on the scientific side and with the help of the Israel Innovation Authority.
So are you in trials already?
We're not in trials, but we're expecting to start first in human within 2021.
Great, amazing. And this is the strength of bioconvergence, is that it really brings together all players, sometimes very surprising players. So we will now hear from different players, large players in the ecosystem. We will talk to a pharma company, we will talk to a medtech company, and even to Microsoft. Bioconvergence is changing the future of healthcare, and medtech companies are already integrating the new digital health and AI technologies into their products to facilitate this convergence. Elad Benjamin, business leader for radiology informatics at Philips. Can you share how medtech companies view this change?
Thank you, Anya. And indeed, bioconvergence is a domain that we'll see more and more of in the next few years for a number of reasons. One, we see, for example, with the current COVID pandemic, it's really changing the way we practice healthcare, and I think it's going to continue changing the way we practice healthcare. And in addition, we're going to see the digital world start to intermingle, as you've said, with the biological world to help bring better care to our patients. And to that end, I want to highlight a few specific things that I think are going to make a real difference in how we treat our patients. The first, as we look forward, patients are going to be looking for convenience. No longer is the default to go to a doctor, to go to a hospital. People think twice. And to that end, we're going to need to find ways to remotely monitor our patients in order to understand how they are, whether it's at home, whether it's at work, and to understand whether or not they display symptoms of abnormality of any different types of conditions. Because as I've said, it is no longer the default to have a face-to-face interaction with their caregivers. So not only is it enough to track now, if we have the mechanisms to track patients, to provide them that convenience, we also need to be able to be aware of the context of those patients. So different patients showing the same symptoms, the outcome may be different and the treatment paths may be different. So not only do we need to provide constant monitoring, but we also need to be context aware of the patients, their patient's history, what their prior medical conditions are, where they are geographically, and other conditions that may affect how we treat them. And this obviously ties in to what in the biological world we treat them with. So we look at remote monitoring, constant monitoring, we look at context-aware monitoring and gathering of information. And as another component of that, there's also understanding risk. As we see, especially today with COVID, understanding the risk of a population. Which patients are more at risk of infection, which patients have a higher likelihood of infecting others, how does the disease spread? So the ability to track populations and to understand the risk profile of different populations in different places is also going to be extremely critical in informing us how we take care of our patient populations going forward. Another component of bioconvergence is security. As we gather more and more data, as we gather it remotely, there's going to be an increased emphasis on making sure that patient data really is secure and that patients can count on the enterprises that they work with, on the physicians that they work with, on the companies that they work with to make sure that their patient data is kept secure, transferred in a secure way between physicians and enterprises as well. And if we take it to the next step, so we're able to monitor, we're able to understand risk, we're able to understand populations, and we're able to understand context of patients, Now we have to be able to take that and to actually provide care. And care is divided into several aspects. One is real-time care. So if we need to interact with patients in a real-time setting, emergency settings, all of that data that has been gathered has to be made available to units or to physicians or to EMTs that are taking care of patients in real time, so that obviously the right patient intervention or treatment can be provided. Additional aspects of the bioconvergence trend are also obviously going to be things around genomics. Genomics is advancing at significant speeds. It's not just the sequencing, but it's also the interpretation and the understanding of what a certain genomic profile has to do with certain disease types and susceptibility to certain disease types. So that is yet another data point and another layer of information that is going to be added in order to be able to take care of patients in the right way with the right biologicals. Another component is diagnostics, whether it's imaging, advanced visualization, quantification of diseases in automatic digital ways, and all the AI and decision support tools that come along with those capabilities to inform the caregivers on how to better take care of their patients. And yet another aspect is pathology. As we gather more information about our patients, pathologists, whether it's for oncology, biopsy purposes, et cetera, need to understand whether the right treatment has been given, whether patients are in the clear, so to speak, and that is yet another layer of information that is added on top of all the other types of information that we have. So to summarize, we have significant amounts of information being gathered on an ongoing basis that allows us to track patients, understand their context, provide them the safety, the security, the feedback that they need to the physicians in order to understand what really needs to happen in the context of taking care of our patients. And all of that is going to merge closer and closer with the biological world in order to provide better care to our patients overall. I think it's an exciting time, and we've yet to see many innovations come through. Thank you.
Dr. Elan Harari, Vice President, Therapeutic Area Head of Neurology and Psychiatry in Global R&D from Teva, Israel's largest pharma company and the world's leader in generic medicines. Teva's innovative R&D has evolved in the past few years, focusing on several core areas, but also introducing new disciplines to traditional pharma development, specifically using innovation to help reinvent medicine. And there's nowhere better to do this than in a world-known Israeli innovation ecosystem. Please share with us the pharma view of the changes and opportunities in the bioconvergence world.
Teva has been looking very thoroughly into technologies to help her create the new frontiers of new medication and new treatment for patients. Recently, senior management from Teva R&D came to Israel and screened about 400 technologies, labs, and met with various scientists from all over the country. They were amazed by the abundance of innovation and talent in the country, and actually came up with agreements with almost 12 scientists, 12 labs, that will help Teva to come with the new treatment for patients. And this is only the first cycle in that process. What we're looking at in Teva is to combine biology and new technologies, bioconvergence, and that actually takes us from the early development stages, finding new molecules, new proteins to develop into drugs, but also throughout the full process of clinical development, meaning even when you go into human and run clinical studies, how to make those studies less expensive and more rapid. We're looking into technologies like quantum computing. We were looking into those technologies. Even infrared technologies that can be implemented in our clinical trials or in our process of drug development. We are looking into databases to combine them in our clinical trials and clinical development opportunities and efforts. And we are also looking into wearable technologies that have many companies in Israel that have an amazing potential and amazing technologies to be combined with our clinical studies. For instance, one of the things we're doing right now in our clinical trials is moving into remote monitoring of the patients, moving into application that can give you data and more information about the patient and the treatment effect of our drugs in those clinical trials. So the combination of technology, the most advanced technology, not coming from biology, and the biology that we are expert in, this combination can give us an advantage in moving forward in treating the patients. One of the things that I can give you as an example is the DigiHaler, which is an inhaler for asthma patients that is combining information and electronic technology to give more data to the patient and the caregiver when that patient is being treated, and this has been approved recently. The other thing that we are looking at is trying to minimize the time that takes us to develop a drug from the beginning to the end. And one of the things we are looking at is how to minimize time by designing the clinical trials in a more efficacious way. Efficacy comes from the combination of new technologies like wearable sensors, like using applications and using remote monitoring in our clinical studies. This runs from phase 1 studies all the way to phase 3 studies and even beyond. What we found is that these technologies are, most of them, if not all of them, can be found here in Israel. And the innovation and the innovative thinking of Israeli scientists combined with our needs and the capabilities that we can find in Israel actually makes Israel one of the best sources to this combination of bioconvergence.
Tech giants are the surprising leaders in the healthcare revolution and have been the first to invest heavily in healthcare AI, wearables, and telehealth. Adas Bitran is head of healthcare at Microsoft Israel. Will you share your perspective?
Thank you, Anya. Microsoft has been working with the healthcare industry for more than 30 years. We have more than 170,000 enterprise customers. This is an important industry for us. We also see healthcare as one of the most urgent applications of artificial intelligence, and we're working with our customers to help them implement artificial intelligent power solutions on their premises. Our work in Microsoft Healthcare is diverse and broad. We develop things like language technologies for text and speech, machine vision technologies, medical devices, signal processing, fire data technologies, genomic sequencing. We even develop technology to map DNA sequences of T-cell receptors to antigens to better understand the immune system and assist in diagnosis. So those are some of the things we do globally. Some of those technologies are developed in Microsoft Healthcare in Israel. I can speak about a few of those. We have our conversational AI technology, the HealthBot, that is a platform for building virtual health assistants and chatbots. It's generally available. It's been out there for more than a year. We had thousands of customers, but it played an important role in our COVID-19 response. Since the beginning of March, we've had about 2,000 different COVID-19 HealthBot instances that served around 400 million messages to more than 30 million end users all around the world in 23 different countries. We are helping those chatbots are helping our customers, governments, providers, frontline healthcare organizations to provide their COVID response. We've also launched a service in preview. We just announced that service in preview. We launched Text Analytics for Health, which is an NLP service for the analysis of clinical and medical text, which can allow our customers to extract insights from unstructured clinical data. A lot of the clinical data around the world is raw text, unstructured raw text, and it can allow our customers to extract insight, support quality control processes, automate processes, support interoperability, and that's currently in preview. Another thing that's in preview is our clinical trials matching solution accelerator technology that aims to expedite clinical trials recruitment based on trials eligibility criteria and patients' data. At any point in time, there are about 50,000 clinical trials around the world that are trying to recruit patients for their studies. This match is not easy to make because clinical trials come with a lot of inclusion and exclusion criteria. For COVID-19 alone, as of today, there are about 2,000 different clinical trials that are looking to recruit patients. And indeed, our first deployment of this clinical trials matching technology was for finding COVID-19 clinical trials around the world. We've been also working with the COVID-19 Plasma Alliance, the fight is in us, to build solution for sorting out eligibility of patients to donate plasma to support developing a cure. So those are some of the things we've been working on. Our goal is to empower the ecosystem and help our customers, the healthcare organizations, to leverage AI to improve their services and processes and eventually also outcomes for patients.
Thank you, Mr. Das Bitran, for these inspiring words. And now I have the pleasure to talk to Gary Kupelevich, who is a partner and head of International Healthcare and Life Science Department at the Lipa Meir law firm. Gary, I think that this pandemic and the time that we live in give a lot of attention to the privacy right. We see a lot of dilemmas around privacy, from contact tracing to use of personal data in order to assess personal risk. And we understand that privacy is the forefront. How do you see privacy and the right for privacy at this time?
Well, frankly, I think to a certain extent, privacy still remains something quite elusive. Looking at it from a far or further perspective, it's a fairly multifaceted definition or actually a concept which makes it hard to set a definitive legal or legal workable definition. And therefore, the answer is not a simple answer. But obviously, the issue of privacy and perhaps the almost inherent conflict between privacy or the right to privacy and the public good, or the core, let's highlight it as we are in this difficult time, the core right of the public to health and safety as compared to an individual's right to privacy.
So we understand that the person cares about the personal information and personal health information, but at the same time there is a dilemma how to protect the public. What do you see in this time, how we balance or how do we change the balance between privacy and public health or public safety?
Well, I think perhaps we should first ask whether we should change the balance. But in light of recent alleviations in regulatory regimes and the leading regimes, for instance, in the US and in the UK, it does appear that there is a certain shift in this balance, perhaps in favor of the public, whereby rigid enforcement of legislation and regulation, where that 6 months ago perhaps seemed to strike the right balance, today endangers lives. And therefore, I think the regulator has also come to the conclusion that a certain relaxation of regulatory rules is actually necessary.
Could you give us some examples? Because I know that, for example, HIPAA, which was protecting personal information in the US and primarily how personal information is being shared, is now relaxed through some kind of recent interpretation. How would you look at HIPAA or healthcare providers in current times giving this relaxation?
Well, I actually think that the regulator is making a lot of sense, if I may say so, to the extent that, firstly, there is a relaxation, as we both mentioned. However, it is piecemeal and a careful relaxation in very particular areas, for instance, in telemedicine or telehealth, for instance, in information that's being given to first responders. And there are other examples as well. So we do see a relaxation in the use and a disclosure of protected health information, which previously was more forcefully regulated by HIPAA, for instance.
But would it mean that someone who shared or gave consent previously, that someone would collect their personal health information, now at the risk that this information would be disclosed with third parties that intentionally they were not supposed to get access to this data?
Well, these are difficult times. And I think the regulators have come to realization with the fact that, yes, due to the emergency and the urgent need to use this data, be it, the obvious to treat, but there are less obvious, perhaps, purposes, for instance, locating, contacting, screening, flagging people, actually require, or if usage is made in good faith by care providers, that yes, some information previously that was not open to the public could actually be made open to the public.
Before we wrap up, so we said there is a new balance and certainly relaxation by the regulators. Is there a potential to use technology in order to both protect information, but at the same time to make it accessible and utilized for public health purposes? Do you see the potential in new technologies solving this balance?
I think that seems to be the way ahead. As I said, there is a shift in the balance, but presumably, if there was the technology that could maintain this carefully structured balance, and on the one hand, protecting the privacy, and on the other hand, allowing questioning data and arriving at conclusions that would assist in prediction, treatment, research and development, then yes, that would be the technology of the future.
Thank you so much. I think in this conference we'll cover some of the technologies that try to strike this new balance of protecting information through encryption and some homomorphic encryption, but at the same time enabling access. Yet the potential is still questionable, but certainly there's a promising path that this conference is trying to unfold. Thank you so much for your important insights on privacy.
Thank you. Thank you, Nimrod.
So after finding what the legal aspects of drug development and health provisioning, now let's shift to the development itself. So I have with me Ohad Goldberg, who is the AstraZeneca Israel company president. Ohad, I want to take you this moment, I guess in February, when we understand there's a world pandemic. You're a president of a company that developed a full line of drugs, a full line of digital health services. How does it change your priority? How does it change the way that you manage the pipeline of products and services that you were developing at that time?
So I think the title is uncertainty, right? Because now in hindsight, we know much more than we knew in February, March. But the reality was that we didn't know how to assess the situation. It was evolving very quickly. And I must say, it's very basic, but our first concern was first of all, safety, and the team safety, the ability to continue conveying life-saving medication. So I think we first of all prioritized what is currently life-saving and what we need to keep procurement and production of, which was of vital importance, and then try to assess what we continue and what we don't. But with the criteria of, first of all, life-saving, what patient needs first, what our employees, how we keep them most safe. And then we started triggering other activities. But I think that was the first one. We did all the senior management team did a full-day workshop around scenario planning, understanding exactly what we do. And we also put in a social element of how we contribute, how we free budgets to help specifically the Israeli ecosystem that we knew was going to go into crisis. So I think it's, life-saving first, understanding that there's a lot we don't know, and starting to convey budgets to other directions.
Given that your company is one of the leading companies now in the race to the vaccine, and we expect the vaccine to be ready soon, what's the new dynamic of developing a vaccine? We understand there was a lot of flexibility or acceleration in the processes of developing a vaccine. What was the reality of development which is different than how we develop drugs in normal time?
So first of all, AstraZeneca is partnering with the Oxford Group here. So AstraZeneca is giving the production and distribution commercialization. And I think, first of all, is partnering with the people that know best, right? It's understanding what you know and what you don't. It's partnering with the leading development in vaccines, moving very rapidly. I think AstraZeneca, first of all, needed to ensure that there is enough supply capacity. So you think about, we're actually creating 2 billion supplies of vaccination when we don't yet have firm understanding that this vaccine works. And this takes a lot of risk, a lot of work with governments. And then, as Leif said, the pandemic is there, the patients is out there. So it's just getting the trials as widely as possible out. We already have phase 2-3 running, which you think about it, the first vaccine was actually constructed early Feb, late Jan, and we're already in phase 2-3. This is dramatic acceleration.
We understand from conversations we had that regulators were adapting the way that they enable this kind of like parallel phases or parallel stages in the development. How did you experience the regulator reaction towards the vaccine development?
So I'll take a step back from vaccines for a second. AstraZeneca works in devastating diseases, right? Cancer, heart failure. For quite a few years, and we're looking at regulator, but if I look at the FDA, there is a lot of breakthrough therapy designations. So there is an open understanding that there are therapies we need to move fast upon, that there is currently no standard of care or not an adequate standard of care. AstraZeneca has a lot of experience in accelerating with the regulator based on that understanding. I think here the situation is exactly like that. The regulator understands that there is a devastating need. We move quickly. Obviously, all safeguards are in place, but you have a constant discussion with regulators. And that's the same for all pharmaceutical companies. So it's about the vacuum of therapy and how much we need to work together.
Well, there is certainly an Israeli perspective. You are the president of AstraZeneca in Israel, and AstraZeneca, I think, expressed a lot of confidence in the Israeli ecosystem by signing recently an agreement with JVP to open a hub for digital innovation. What's the reason you chose Israel, and why Israel is attractive as an ecosystem for innovation?
So AstraZeneca has been in Israel for a bit more than 12 years. I think it took us maybe a bit more time to understand and to get the full endorsement. But we saw, first of all, the level of science and the level of medical practitioner is just outstanding. We know there is a thriving phase 1, 2, 3 clinical studies across the Israeli centers. And if you put on that the electronic medical records, right, that each sick fund has, the unique ID number, with the cyber technology, the ecosystem around technology in general, whether through industry, military, you bring these all together, this is exactly what makes innovation happen today. And once we could get the full corporate endorsement to that, the going forward was very easy. And within 6 months, 7 months, we have 9 startups working in different area of prediction, of electronic data, of decision support tools, which is really very fast. And when I don't think in AstraZeneca globally there's such a fast cycle of innovation, which just shows what Israel has to promise.
One question on that. We see that the pandemic not only changed the way that we go with medicine, but also changed provisioning of health services and caregiving. How do you see this innovation or trends in innovation that probably will evolve with the pandemic?
So first of all, it took COVID transformed the way we work internally, right? We started working virtually within a day. I think the physicians are seeing the same thing. I talk with a leading specialist in Israel, and they've gone to 50-60% remote consultation where possible. Obviously, they need to see the patient, but moving much more to remote consultation, very quick adaptation of sensors and monitors where possible. Obviously, the world is not perfect, but there is much more ability and time to listen and adapt these technologies. I would envision a world where we go much less physically to the physician, where we self-diagnose based on sensors at home and platforms, digital platforms. That's, by the way, one thing we're investing in Play Beyond Bio. All this together, at the end of the day, will bring better care for patients.
One can guess it's a good time to be a data scientist if I want to penetrate the digital health innovation in Israel, because it's going to be more about digital innovation rather than about science and medicine?
I wouldn't say that it's going to skew 180 degrees that direction, but I think it's the good place to be, whether it's in epidemiology, whether it's in science, whether it's in tech, and the ability to bring them together is exactly what's happening together. And as a pharmaceutical company, being able to really to bring a promise with vaccination on top of these three elements is the place to be. Unfortunately, it's in a devastating situation, but that's where we prevail.
Thank you so much, Ohad, for these inspiring words and for the promise for Israel innovation ecosystem. Thank you so much.
Thank you.
I'm here with Agnes Berman-Pivnik, who is a marketing manager at Q Medical Devices. Agnes, I wonder, a global company that produces OEM products for emergency room and clinical care, line of products both for elective surgery but also for the emergency care. How the pandemic, COVID-19, meets your company?
So way back in March, we have received, like all the medical device manufacturers, this increasing demand, very, very dramatic demand increase in our critical care products. We are manufacturing the bread and the butter for the ICU units and emergency units for patient monitoring and measuring the vital signs of critical ill patients. And we have received this increasing demand. We could see over the days how the demand peaks in the critical care area and how the demand just flows down and almost stops in the cardiovascular area.
So here's a challenge. You have production facilities all around the world. You have factories, both in Israel but elsewhere. And at one point of time, you have to take decisions about how to prioritize production.
We are having a critical team, a critical crisis team that looks over the life cycle of the product from its beginning to the end, through the supply chain and the operational modus. So first of all, we had to work with our suppliers. It is critical for our operations to have a very strong basis of raw materials and components. And here we have gapped this demand by working with each of the suppliers. In some cases, we have 2 suppliers, so we were able to gap this demand. And then when we bring them into the production, we had to map our production facilities. And to add another dimension was the fact that some of our facilities were a total lockdown. Like, for example, in India, from one day to the other, we have seen a facility that numbers 1,000 people that it's closed. The borders are closed. So we had to deal with shifting of production in different other areas in Israel, where we have 2 facilities, in Slovakia and France, and to see how this can be performed without breaching the regulatory and the quality restrictions that we have with the product.
So here, Agnes, the challenge. We know that in medical devices, you plan ahead of time. You have a very detailed planning for years in the production facilities, which need also to meet quality assurance and regulatory burdens. How flexible is the regulator in changing production lines? How flexible is actually the quality control when you shift from production of one device in the factory to another device?
Actually, it is not so simple. We need to, in order to be able to do major changes, we need to do the validations of the products from the beginning for the same processes. But if we use the same process, the same machinery to manufacture 2 types of product, then it is possible. So total shifting of production is enabled only after we have the product validation and we ensure that the quality of the product is the same as the original manufacturing.
Were regulators more flexible at this time for changing line of products?
We haven't seen this. Unfortunately, the regulation, it was still standing on. We haven't seen any changes in the regulation, and we don't have to supply all the changes. We have to have them inside. So,
Agnes, another challenge, you're a global company. You're supplying the demand in so many countries around the world. and countries are competing with each other for access to medical devices. We've seen stories where companies are holding actually products or controlling the export of products which seem vital. How a global company with demand all around the world manages this kind of like macro world economics at a time of crisis?
First of all, we have calls and we have continuous communication with our customers. We have set up this once a week meetings with all our major customers and with the hospitals in Israel, which was one of our challenges and our goals to provide continuous delivery in the hospitals in Israel. And what we are doing after the demand is reviewed in a weekly basis, we are going back to the planners, to our industrial engineers, and we are managing the production with a tweezer. It was a very, very challenging situation, and we understand that for a company to be able to succeed and to produce these products, we need to be flexible. The new normal situation is the constant changes. So we are in this situation where we understand that changes will happen and we will have to give them solutions.
Thank you very much, Agnes. It's a pleasure to understand a little bit the dynamic of production and manufacturing at a time of crisis. Thank you very much.
Thank you for having me.
That concludes our fourth session for the day about bioconvergence. I think we had an exciting opportunity to hear from experts from the fields of robotics, nanotechnology, engineering, genetic engineering, how they applied the knowledge and the research from their field into the health sector, how biology is being served and accelerated by innovation coming from other fields. Thank you so much for being with us at FutureMed 2020.